Okay, if you check on the participant list, you can see the attendees as they're clicking in right now.
So we can toggle back to the continuing medical education instructions, good morning, Dr. Sky. Thank you for joining us.
Good morning.
And Cindy, are you going to be running your video?
Oh, no, I am not planning on running the video today.
Okay.
Can you hear me all right, though?
Yes.
Yes.
Okay, thank you.
So let's go to the directions page, please. And thank you, Dr. Bommer, for putting these directions together, if you'd like to verbalize them.
So welcome to our current attendees and participants. Today is again a Zoom novel experience for all of us, but certainly one that over the last 6 months we've all gotten very familiar with. So we are going to run the program today, and to make it a little bit more interactive, we are incorporating 2 of the Zoom features. One is the chat box, and the chat box will be on all of the time. It will allow you, if you select the chat box, and in most cases, if you go to the participants button and click on it, you can see a chat, or it will be on the top of your screen as chat. And if you click on the chat box, and on mine, it actually is under more. So it may be different on programs that are Microsoft versus Apple. Mine is listed under more. You should probably have a little button at the top or bottom of this page that says chat. Chat will be live during the entire program, and you can type in your chat remarks, and the chat remarks can be sent either to all participants or sent to just a specific participant that you have identified. So use that, and during the Q&A session, we will try to summarize some of the chat comments that have come in for that. In addition, during the question and answer facilitator area, you can also select the raise hand, and the raise hand function will identify you as having a particular question. If you put raise hand on, our coordinator will try to select the raised hands, and she will then unmute you. You will receive a message that says you're unmuted from the host, and you will now have to unmute yourself by going to the top or bottom of the screen and hitting unmute. At that point, your microphone will be live and we'll be waiting for you to pose your question to the panel or to the speaker, however you direct it. So these are the 2 interactive areas, both chat and raise hand will be used during this program today to try to make it a little bit more interactive, because to be honest, we know this material. What we're really interested in is perhaps some of the questions and answers and what your concerns are, because those are important to the medical community and to the general community as well. as we go through this area of unknown for many of us at this time. So I think we are getting close. So I'll just repeat that again. Today, welcome to the Right Care Initiative. We will be starting the meeting at 12 p.m. And we will record the message or the meeting. So if you make comments, realize that those comments will be recorded. And we have two ways of interacting for questions. One is live during the entire program is the chat screen or chat button available through Zoom with the directions given earlier, as well as raising your hand. The raised hand will only be answered during the facilitated Q&A session where you'll be recognized, and then you can verbally or on the audio state your question to the participants, speakers, and to the panel that we have. Now, as an introductory to get practice on this, why not try just clicking on the chat button on your screen right now and put in just any type of a test. So we're suggesting, what are you grateful for today? Hopefully everyone has at least something that they can think of that is positive today, and you can put it on the chat line. And that chat line and your comments will be visible to all participants if you direct it to all participants. So why don't you try, if you could for us, click on the chat button. And on the chat button, if you click on it, there were comments that we have so far. Happy Monday is a good one. Thank you for this program. Sunny day, so that must be California people that are selecting that one. Blue sky, good health. So hopefully, I'm happy to say all of our panelists are in good health today, so that's good. And hopefully all of our participants are in good health as well.
Thank you, Dr. Bommer. We're now at the top of the hour, and I'd like to welcome people from not only across California to the Right Care Initiative Virtual University of Best Practices, but also increasingly people from around the nation. We're so pleased that we have participants from the Centers for Disease Control, the Centers for Disease Control Foundation, the National Heart, Lung, and Blood Institute, and the Surgeon General's office, in addition to leadership from San Diego, Los Angeles, the Bay Area, and the Capital Region. And we have very special guests with us today to help us jointly work toward our metrics goals that we know, as you can see in the slides behind my head, drive down heart attacks, strokes, and diabetic complications. So our goals are in sync with the Million Hearts goals, which are to get 80% of the population who needs to be controlling their cholesterol, blood pressure, and blood sugar to goal. We synchronize our goals with the data that's collected nationally to make it as easy as possible on the health plans, medical groups, clinics to reach these targets. We are a large collaborative that's been building since 2007 around these goals. And our work is associated with reducing heart attacks in particular very quickly by driving LDL to less than 100, blood pressure to less than 130/80, and blood sugar to less than hemoglobin A1c 8. We do this through this, this graphic that synthesizes clinical best practices that we know can very quickly and effectively get to goal. So with that, I'd like to say that the key is activating the patient, doing team-based care, getting commitment by leadership, and I'll hand it to our Capital Region Chairman now to lead the discussion for the rest of the day. We have leadership from all over the state with us, and we're just so grateful for everyone's passion and commitment to this, and particularly to Dr. Larry Sperling, the founder of Preventive Cardiology at Emory, the Preventive Cardiology Center, and also the Million Hearts Director. When he and I discussed this presentation back in January in San Diego, we had no idea what we were up against. And I just say thank you all for your passion and commitment to these shared goals. And thank you, Bill, for introducing Dr. Sperling and the topics for the day.
Thank you very much, and welcome again, everyone. If we could go to the first slide, next slide. So today's program, as you know, is part of, as Hattie said, our continuing once a month multiple location programs throughout the state of California and now throughout the nation as we go farther. We do want to recognize that we have a number of chairmen of our programs, Dr. Chen, Dr. Demaria, Flinn, Giambroni, Dr. Sky, Zer, and we want to welcome all of those in the program for that. They are clearly the boots on the ground that take care of the program on a day-to-day basis, and they're very important for us. The program today is shown here, and the first talk will be the future of cardiovascular prevention by Dr. Sperling. The next talk will be the National Medical Association Collaborative, which is called Release the Pressure, the Importance of Hypertension by Dr. Oliver Brooks. We will then have a commentary about both of those talks with our facilitator, Dr. Anthony Demaria, and Scott Flinn and Joe Sky. We will then go on to leveraging data warehouse, the importance of medical information in this era, and this for both cardiovascular and COVID disease. Then have a facilitator with Dr. Chen completing it on the commentary of the program that we have presented today. Next slide. So Hattie mentioned earlier the focus of right care and how they approach it. And a little historical here is on the left is shown when right care was initiated, there was a separation of hospitalizations in California on the top versus San Diego. Right care first started for the University of Best Practices in San Diego. And there was an association of a reduction of hospitalizations for heart attacks in the city or the county of San Diego at that time, just at the time when the right care best practices began to be implemented. That was also associated on the right with a reduction in the all-important mortality or death rate for disease in San Diego County, which showed a continued drop in mortality as well. Those initial efforts, next slide, were expanded to 4 areas. So we went from San Diego to the capital or Sacramento area, included a program in Los Angeles, greater Los Angeles area, and also the San Francisco, San Jose Bay area as well, where the program is. The graph on the right shows the capital region, and it shows what we do in many of these areas is we have a bar, the red line, where we're trying to make this target for, on the top, blood pressure under 140. At the bottom, or the next is blood pressure under 40 for diabetic people. And then we have glucose or A1C control for people with diabetes, followed by cholesterol therapy, controlling it in people with existing cardiovascular disease, Our goal is to achieve the red line target or higher in every one of these areas and every one of these group medical practices. Obviously, there has been some progress in many of these areas, but we have a long way to go. You can see that we are not above the red line for a number of these areas, and so we still have work to do to get better compliance and control of blood pressure. That will be discussed today by Dr. Brooks, as well as control of diabetes, which we've had programs on, as well as cholesterol control, which we've also focused on. Next slide. So we do have work to go because we still have deaths in the US. You can see that on the left, every 37 seconds in the US. So even while I've been on this slide, there has been a cardiovascular death. So we are trying to prevent that. So it is critically important that we improve our prevention for this to prevent it. We also are trying to prevent cerebrovascular events or strokes, since those are also vascular. Cardiovascular is the important one. Heart disease and cardiovascular disease is the #1 killer in the United States, so we are focused on that. But in the middle of our focus on cardiovascular disease, a curveball was thrown or showed up in the middle, which you can see as the COVID virus. And not only do we have to today battle the cardiovascular mortality every 37 seconds in the US, but we now have to endure a COVID death every 80 seconds. So we've added to that. And COVID affects primarily individuals who are older or have existing cardiovascular disease. So we've had to expand our focus now to include an additional disease. If things weren't bad enough with just garden variety cardiovascular disease, now we throw a coronavirus on top of it, where the cases are increasing, and we had over 1,000 cases, as you can see there, or 1,000 deaths a day that we're enduring. And within the 80 seconds I've been speaking, we've lost someone from COVID as well. Now, there are really no cures for cardiovascular disease, stroke, and for COVID at this time. So we have treatments, but they are not curative. So our best way to treat or handle these patients is prevention. Prevention works for cardiovascular disease, for strokes, and it also works for COVID. Next slide. So the key to trying to handle these pandemics and epidemics in the past has always been and will be prevention. And on the left is the CDC for ABCS for that, for aspirin, blood pressure, cholesterol, and smoking cessation. On the right is the American Heart Simple 7, where they add diet, weight loss, and exercise to those parameters, and glucose monitoring as well. So if we in fact can prevent by lifestyle a lot of these things and preventive treatment, we can in fact reduce the chance of getting cardiovascular disease. And at the bottom, we can see that currently for coronavirus, the best thing we do have to offer is prevention. And the CDC recommendations are seen there. We're both sanitizing your environment and avoiding contact with individuals with distancing and mask wearing. So those are important areas. But everything on this slide is prevention. Why? Because we have very little for curative for cardiovascular and COVID at this time. Next slide. So that brings us, since prevention is the only way to go for the current cardiovascular and COVID disease, we brought in the expert on prevention. So the program today will be Larry Sperling, who, as you can see here, is a professor in preventive cardiology, is the founder of the heart disease prevention program at Emory, He is the past president for preventive cardiology and is the chair on prevention of cardiovascular disease among people with diabetes. 4 prevention titles are here. So there's no one better really nationwide to talk about prevention than Dr. Larry Sperling, who is our guest today. Next slide. So talking the talk is important, but many of these preventions are lifestyle. So I've shown on the top of the slide the graphic from the Athens Marathon. Athens Marathon is 26 miles. The start is shown on the right, and the black arrow points to an individual in the middle of the crowd there. That individual is Larry Sperling at the Athens Marathon. On the bottom of the slide, you can see, and that's at the start. The bottom of the slide shows the path he took from marathon, running 26 miles all the way over to Athens, to the finish. And on the left, you can see one of the early finishers was a foot soldier who was the first one to complete it and actually said a few words and then expired right there on the site with his announcement. Well, fortunately today, Larry has finished the race and he still has things to say. So we have him today for that. I thought I would also point out in the middle of the slide is Larry's actually finishing time in the race that you can see. So he finished in about 5,000th place. So there were 5,000 people ahead of him at a time of 4:44:23 for the race. So very impressive at that point. You can say he is a leader and a follower. He followed 5,000 people when he crossed the finish line, but he was still ahead of about 6,000 or 7,000 people at that time in a crowded race. I show the times that are circled there for importance. You can see in a typical marathon that's this crowded, and I show the start up there, the race starts and you're still a long way from the start line. And you can see Larry had to run a whole minute before he even got to the start line at that point in time. And what you can see is from the comparison of Larry with Ian below him, that Ian was clearly 30 seconds ahead of him and much closer to the start. But in the race, perseverance, resilience are important for everyone. And Larry not only made up that 30-second lag, but beat Ian by 3 seconds at the finish line, so showing that he is a competitive marathoner as well. And I talked to Ian earlier, and he is going to zoom in on us at this point in time so he can give Larry some comments about how he beat him in that last 3 yards of the race. But we're happy to have Larry here. He is not only going to talk about prevention, he not only talks the talk, but he walks the walk. And we will see that on the next slide. This is Larry Sperling. I'd mention one thing here. He is well accomplished in all areas of academic, teacher, writer, award winner for everything. And he has been an invited speaker on every continent except Antarctica. So we did wire Antarctica ahead of time, and I believe there are at least 2 penguins tuned in on the Zoom today. So with that, we're happy to present our guest speaker today, Lawrence Sperling.
Welcome, Dr. Sperling.
Well, thank you. Wow, that was the kindest, most wonderful introduction I've ever had. Thank you, Bill, and thank you, Hattie, for allowing me the opportunity to speak with all of you today. I'm grateful to be visiting with you virtually, zooming into California. Many of you were grateful about the blue skies and sunshine. As I'm looking out the window of my home office here, We're about to have a major thunderstorm and a lot of rain. So hopefully I'll be able to remain on the call throughout my presentation and beyond. What I'd like to do today is talk about the post-COVID future of cardiovascular disease prevention with hopes that there absolutely will be a future. The next line, please. Next slide, please. Importantly, today I am representing myself, and so my comments today reflect my comments and not the comments of organizations I work for, work with, or serve. Next slide, please. So before we talk about the post-COVID future of cardiovascular prevention, I'd like to talk to you a little bit about the past and then certainly emphasize the future because, and certainly emphasize the present because all of us are very much living in the present right now, minute by minute, hour by hour, and day by day in the setting of our current pandemic. Next slide. So as I talk about the past, I'm going to refer to the past as BC because right now BC refers to before COVID. Next slide. This photograph here introduces all of you to the father of cardiovascular prevention, Paul Dudley White. And Dr. White was an advocate for the prevention of heart disease. He was a major impetus behind starting the Framingham Heart Study. He helped to oversee the creation of the NHLBI and start the American Heart Association. And he became President Eisenhower's physician following President Eisenhower's myocardial infarction in 1955. Paul Dudley White also walked the talk. He was known for exercise more, eat healthy, learn your family's medical history. Next slide, please. And my Athens marathon, the marathon time was definitely not my best time, but it shows how we need to be slow and steady and persevere to win the race. Paul Dudley White's last fellow at the Massachusetts General Hospital was Willis Hurst. And Dr. Hurst was a significant mentor to me. Willis Hurst was chair of Emory's Department of Medicine for 35 years. He's well known for Hurst the Heart. Brunwald's and the Heart are the two most cited texts in cardiovascular medicine across the world. Willis Hurst also became a president's cardiologist when Lyndon Johnson had an MI in 1972. And Dr. Hurst was extremely encouraging of me to help start the preventive cardiology program at Emory back in 1997, one of the first programs of its kind in the US. Dr. Hurst passed away at the age of 90 in 2011. Next slide, please. So before I was born in 1961, with just 2 words, Bill Cannell helped to change our understanding of the underlying causes of heart disease and stroke. And with these 2 words, the entire field of preventive cardiology was born. I'm sure you can guess these 2 words. Next slide. Risk factors. And so today we very well know the traditional cardiovascular risk factors: age, gender, hypertension, hypercholesterolemia, smoking, diabetes. And if we can go to the next slide, please. What was described in Framingham was that these risk factors, when you had multiple risk factors, which many of our patients do, there was an exponential increase in cardiovascular risk in both men and women. Next slide, please. Back in 1940, so this is now 80 years ago, when Franklin Delano Roosevelt dedicated the National Institutes of Health, he said that we cannot be a strong nation unless we are a healthy nation. And I'll remind you that it is the National Institutes of Health and not the National Institutes of Disease. Next slide. Well, talking about the past, each and every one of us have a story that touches our heart. And part of my significant interest in developing a career in heart disease prevention is related to my family's history. This photo here is of my grandparents, and Morris Wilner was my grandfather on my mother's side of the family. He had his first heart attack in his mid-40s and unfortunately died too early of a disease today that we know can be preventable in many, many of those who are living with it. Next slide. I've been fortunate to serve many organizations. I still work in a consulting capacity with the World Heart Federation. I've had a chance to learn from many leaders across the country and many leaders across the world. And so these two quotes from former presidents of WHF, I think we need to take to heart. From Salim Youssef, cardiovascular disease is the biggest epidemic, and it truly is a pandemic, ever known to mankind. We need strategies to address epidemics. And Valentine Fuster, who is now the editor at JACC, said secondary prevention is urgent. Next slide. Well, this slide on the left-hand panel there, you see a photograph that unfortunately looks very familiar to us today. You see a group of individuals together wearing masks. And what distinguishes this photo from our existence today is the black and white photo and the garb that these people are wearing. But you can see the woman all the way to the right-hand side is wearing a sign that says, wear a mask. This public notification here is saying that during the Spanish influenza, all schools, churches, theaters, movie picture halls, pool rooms, and other places of amusement and lodges and meetings are to be closed until further notice. Next slide. So that last slide was 102 years ago today. These two photographs I took in January of 2020, when we were able to travel and meet with our friends and be speaking in person instead of virtually. And so I visited in San Diego and with the team from the Right Care Initiative at that time. That is absolutely not me doing the paragliding there. I would not do that in a million years. The photo on the right-hand side is a photo I took with the sun going down right before we met with the executive leadership team from the Right Care Initiative for dinner. So our world absolutely has changed dramatically over the past 6 months. The next slide. So I talked to you a little bit about the past. Now we are very, very much entrenched in the present. Next slide, please. This is why we're entrenched in the present, related to COVID-19, a novel coronavirus, which really has been a challenge to all of us in every walk of life, especially those serving in the fields of healthcare and public health. And so I want to thank all of you who are serving your patients, your hospitals, your communities in these fields right now. Those of you who are serving on the front lines and doing all you can to make a difference as we are really moving through uncharted waters. I spent 15 days in a row on our hospital teaching service back in April, during a time we thought was going to be the peak of the pandemic. I was in self-quarantine within my own home for 22 days in a row, and I'm caring for patients through telemedicine platforms, telehealth, and seeing patients in our prevention center at Emory. Next slide. Well, we are still on a really, really steep learning curve because initially, coronavirus, SARS-2, we thought this was primarily a respiratory infection affecting the lungs with a systemic secondary manifestation. And over time, we have learned that COVID has significant impact on the cardiovascular system. We know COVID illness affects endothelial function, thrombosis, It affects through stress, through demand stress, increasing the risk of acute coronary syndromes, the risk of myocarditis and stress cardiomyopathy, Takasobo's like picture. And so we are encountering many situations that we often don't see with other viral illnesses. And we are responding really collectively and together to learn on the fly and changing our clinical paradigms right now through evidence from our country and across the world. The next slide. There we go. So this is a paper that was published now a week or two ago, and this paper really received a lot of attention. It came out of Frankfurt, Germany, published in JAMA Cardiology, and this paper looked at 100 consecutive individuals who had COVID illness, a median 71 days from COVID. They had to be at least 2 weeks from hospital discharge. If you look at the paper, about 20 of these individuals were asymptomatic. About 30 of them were hospitalized, and the rest of them fell somewhere in between, treated at home with mild to moderate degrees of symptoms and illness. And cardiac MRI was done in each and every one of these patients with a control arm as well, a matched control. And cardiac involvement was seen by MRI in 78% of these individuals, active inflammation in 60%, troponin, high sensitivity troponin elevation in 70%. And these findings appeared to be independent of pre-existing conditions and severity. Those who were sickest underwent myocardial biopsy, and here there was evidence of acute lymphocytic infiltration, and it should be severe with an E. So typo on that one. Next slide. Oh, go back one. There we go. So this was the headline of the New York Times in April. Amid the coronavirus crisis, heart and stroke patients go missing. And what we know is these patients haven't been missing. They've been missing from emergency departments, and they've been missing from hospitals, but we think these events are clearly occurring. And there is some data to suggest these events are occurring really in greater numbers than they are when there's not a pandemic. Next slide. This slide points out 2 MMWRs published in the last month or so. The one on the left looks at what I just was mentioning about emergency room visits. And in the 10 weeks following the declaration of the COVID-19 national emergency in the US, visits to emergency departments declined 23% for heart attacks, 20% for strokes, and 10% related to uncontrolled high blood sugar. On the right-hand side, you can see Dr. Bommer had referenced those living with serious health conditions being at greater risk for COVID-related morbidity and mortality. And this MMWR noted that those who are living with serious health conditions had a 6 times higher chance of hospitalization, a 12 times greater chance of death. And this includes those living with cardiovascular disease, diabetes, and COPD. The next slide, please. There we go. Well, this was a paper published in the New American Journal of Preventive Cardiology. I'm a past president of this organization. Amit Kher was the first author. And in this really well done paper, they talk about the waves. And I really look at it as intersecting problems that are occurring in the midst of the pandemic. Clearly, the acute morbidity, mortality related to the viral illness itself, the cytokine surge that occurs in some individuals, and then we have several other intersecting challenges amongst us every day right now. The delay of cardiovascular care and interventions, and then the interruption of continuity of care and clearly preventive care across populations. Next slide. In the same paper, recommendations were made for patients visiting or for patient visits during the COVID-19 pandemic. First is don't defer your patient visits. We have rolled into the ability to help care for our patients in many different forums, certainly electronic forums, through telehealth, telemedicine, or just telephone touch bases. So using telehealth, many of us are really rapidly getting into the world of telehealth and telemedicine. At each visit, ask your patient about symptoms, not only their cardiovascular symptoms, but symptoms that might be reflective of a low-level COVID illness. Encourage your patients at each visit that if they are having an acute event, they should seek emergent care at their local hospital. These hospitals are taking precautions and are ready to care for those who are suffering MIs and strokes and other cardiac events. Remind your patients about this safety. Ensure that they're getting adequate medications and have access to their medications. Inquire about physical activity and nutritional habits. Although not on this slide, inquire about their social situation. Inquire about their stress and their concerns, because this is a really dramatically stressful time for all of us. And then also use the full care team to enhance patient care. Next slide. One of the things that I quickly learned was when I was having a telemedicine visit, that vital signs are absolutely vital for telemedicine. Many patients did not have home blood pressure devices. And so in the space of what we're trying to achieve, a tighter and more collaborative relationship with our patients and their care team, SMBP, self-measured blood pressure, becomes even more important. This wonderful way to link the clinical team and the patient related to their self-efficacy and shared decision-making. Next slide. I wanted to add this slide for this presentation here because it's August right now, but we are rolling into the influenza season. And we know that influenza vaccination not only helps prevent the problems related to influenza-related illness, but there's data that supports that influenza vaccination is cardiovascular prevention. It's an AHA/ACC Class 1 recommendation for secondary prevention. There's data that highlights that MIs are 6 times greater within a week of influenza. So just like with COVID, there's upregulation of many cytokines in the setting of a viral illness, increasing the probability of destabilizing a plaque and causing an acute vascular event. We know that influenza vaccination reduces the burden of influenza-associated illness, including cardiovascular events. And although we have several randomized controlled clinical trials in progress, thus far what we know is the risk reduction, the relative risk reduction from flu vaccine is similar to blood pressure control and cholesterol management, and we should think of it in this way. So we need to be ready for the upcoming flu season. Clinicians who talk to their patients about influenza vaccination have a significant impact on the uptake. And so on a health system level and team-based approach, we need to realize this is going to be the most important influenza season in history to do this right. Next slide. So we are very much in the present. And in the present, we need to keep reminding ourselves that in the COVID pandemic present, cardiovascular health, cardiovascular disease prevention, and cardiovascular care must remain a priority. Next slide. If we look at the trends related to cardiovascular mortality and stroke mortality all the way back to 1950, cardiovascular disease, as Dr. Bommer mentioned, has been the leading cause of death in our country since 1910, with the exception of 2 years. And these 2 years were the 2 years of the flu pandemic. And I hope that cardiovascular disease will not be overtaken by COVID. And that is one of our goals in the months ahead. When we think about these trends also, it's important to recognize that racial and ethnic disparities have been persistent in cardiovascular disease mortality since 1968. But if you look all the way to the right of these curves, CVD, CHD in blue, and stroke in red, since about 2010 or so, these curves have begun to flatten out. They have become stagnant. And what has happened is an uptick in risk, mortality in our country. Next slide. Next slide, there we go. So this slide depicts what is really a healthcare crisis. In the United States right now, over the past decade, we are seeing in 2/3 of the counties of the US increasing mortality rates related to heart disease in the top panel here and stroke in the bottom panel in our country. So 2/3 of the counties in the US are having trends in the wrong direction. I do want to point out, if you look at the state of California, both related to heart disease mortality and stroke mortality, actually, this is a state that we should be looking at as a best practice. Next slide. There are many missed opportunities related to cardiovascular disease prevention. 9 million Americans not taking aspirin for secondary prevention. 40 million with uncontrolled high blood pressure. 39 million not using statins when indicated. 54 million still using combustible tobacco. And 71 million who are physically inactive. So all told, this is 213 million missed opportunities, with over 50% occurring in the younger adult age group, 35 to 64-year-old ages. Next slide. So we absolutely need to change the conversation in the US. Here, this slide points out in the left-hand panel of what we die from. So this is CDC data. 1/3 of the deaths are related to heart disease. And then these next three panels are what we're discussing or what we're concerned about in the media. Google Trends, New York Times, Guardian database. And so we need to connect what we're dying from to the conversation, change the conversation, and connect this to action. Next slide. Another concerning trend is the obesity epidemic tied to cardiometabolic risk and diabetes. This is a paper from the New England Journal of Medicine about 6 months ago now, with the prediction that about 50% of American adults will be obese by 2030, and 1/4 of adult Americans with severe obesity. So clearly, this is an important part of the preventive challenges ahead of us. Next slide. Well, right now I'm virtually visiting all of you from Atlanta, Georgia. This is my home. And I've showed this slide many places around the world. So although we can determine our genetic code, our zip code, where we live, is a much more powerful predictor of health and disease than our genetic code. So health varies at a very local level. In Atlanta, Georgia, if we look at one of our northern suburbs, Buckhead, versus a southwestern region of Atlanta, Bankhead. Driving by car, this is about 15 minutes. And here in the United States, we see a 13-year difference in life expectancy. Next slide. One of our recent fellow graduates, Haval Kelly, and others at our Emory Clinical Cardiovascular Research Institute, we have done some research on food deserts, areas of food insecurity, and about a little less than 10% of Americans live in a food desert. And next slide, or just press the ahead button. The green areas on the slide here, these are not parks in Atlanta. These green areas represent areas of food insecurity. And our research, which has been published, demonstrates that very early on, those living in these regions have greater cardiovascular risk and greater cardiovascular abnormalities that are detectable through measures of physiology and anatomy. So in essence, we live in low and middle income country equivalents in our own backyards here in the US. Next slide. Well, what has happened on a global level over the last 3 decades is cardiovascular disease, ischemic heart disease, has snuck up on us as the #1 cause of death worldwide. Next slide. And this is very concerning even when there is not a pandemic because of our global economy. Americans right now, only 3% of Americans have ideal cardiovascular health. This is through the AHA Simple 7. And about 10% of Americans have poor cardiovascular health with disparities by age, gender, education, and ethnicity. Next slide. And that last slide was from the Behavioral Risk Factor and Surveillance Survey, 350,000 Americans. I served on the writing group of our 2018 cholesterol guidelines. If you haven't had a chance to read the 121 pages of the guideline, I urge you to review ACC Guideline Hub, where you can access guidelines made simple. We were the first guidelines to emphasize 2 value-based recommendations. Next slide. Well, as we begin to talk about our challenges in the present and move towards the future, before we think about non-statin agents, which we now have several, and we have evidence to support their use, we need to be humbled by the fact, this is a paper by Tom Maddox from the NCDR Pinnacle Registry, 2 million Americans cared for by cardiologists, and 25 to 30% of Americans who have statin benefit conditions are not even receiving a statin. Next slide. A former Surgeon General, Everett Koop, reminded us back in 1985 that drugs don't work in patients who don't take them. Next slide. There we go. For several years in a row, I spoke at the ACC Summit meeting about cardiovascular prevention. I called it Doing Well by Doing Good. And this meeting is about the economics of cardiovascular prevention. So I show you here the pyramid of cardiovascular economics right now in 2020, with prevention at the bottom of that pyramid and high-level procedures at the top of this pyramid. As we move towards the future, what will be the post-COVID future of cardiovascular disease prevention, imagine that this pyramid will start turning, and hopefully it is turning at this moment right now, at this inflection point in the history of prevention. The pyramid will turn and someday will stand on its head. And so we will have to think very differently when those high-tech procedures become costs instead of healthcare economical gains. Next slide. So we are all looking forward to the post-pandemic future. We have no idea, excuse me, we have no idea when this post-pandemic future will begin. But I'm going to emphasize that I hope we should begin thinking about the post-pandemic future right now. Next slide. Back in March, on a medical chat site called the Doc Matter Community, a trainee posed a question about the future of preventive cardiology, saying that back in 1918, when the Spanish influenza pandemic led to a following Great Depression, what will be the future of preventive cardiology, which has been deemed a non-essential service in the grand scheme of things? And if you look at the numbers back on March 22nd, 370,000 cases of COVID in the world, 16,000 deaths, and 508 deaths in the US. Next slide, please. Well, these are the numbers I pulled off of the Johns Hopkins Coronavirus Resource Center just yesterday. And so just compared with March the 22nd, you can see where we are here today with worldwide cases approaching 20 million, deaths 723,000, and deaths in the US at 162,000. Next slide. And so I answered this medical chat site, and my answer led to several publications talking about the future of cardiovascular disease prevention. Next slide. So in circulation, there's a On My Mind piece that's called The Post-COVID Future of Cardiovascular Prevention, Unprecedented Times. And in this, I mentioned that the risk for COVID-related morbidity is driven by the interaction of a viral illness with an unwell population. And so there is a need to invest more than ever in essential services like cardiovascular prevention, population health initiatives, and a robust public health program. Next slide. Published in Cardiovascular Endocrinology Metabolism, in a also commentary, we mentioned that cardiovascular and cardiometabolic prevention must be a high-level priority in the post-pandemic recovery and the era of COVID-19, and that the lessons we are learning right now during the pandemic and during the recovery will be critical to ensure the health of populations going forward. Next slide. This is a quote that was on my last office door at Emory, and I've been using this quote often, from Albert Einstein. All of us need to really take this quote to heart. In the midst of difficulty lies opportunity. And so what will be and what are the silver linings of our current situation right now, our current challenges day to day? Next slide. So as we talk about the post-COVID future of cardiovascular disease and cardiovascular disease management, it clearly will have to be a greater focus on cardiovascular health and cardiovascular disease prevention. The next slide. This is a central illustration from a paper we published in JACC now 5 years ago. And in this paper, we talked about cardiovascular population health. This is the health disease continuum. And we should be honest that when we encounter cardiovascular disease right now, at least in the US, we're encountering disease often at a late stage. What we really want to understand better is what it means to be healthy, free of cardiovascular disease, because this will allow us better to focus on health promotion and disease prevention. The next slide. We published this paper several years ago in Circulation, and what we are seeing play out with this pandemic, besides those living with serious health conditions, is that those who are living in health disparities are at also greater risk of morbidity and mortality related to COVID. This central illustration highlights that although we often talk about addressing traditional cardiovascular risk factors, which all of you know very well, and certainly are the tenets of those ABCSs, but really as we address social determinants of health, we need to think very differently and act very differently as we focus on access to care, healthy foods, psychosocial, behavioral, and environmental factors. Next slide. Several years ago, I co-chaired the first ever US Cardiometabolic Alliance. We had 20 or so organizations participating. We published this paper in JACC. Next slide. And as we think about population health or the health of your individual patients, we should think about cardiometabolic risk in stages. Stage A, you're at risk for cardiometabolic disease. And this risk might be genetic or socio-demographic. It might be related to behaviors or the intersection between genes, environment, and behavior. Stage B, you're developing this syndrome, which, by the way, cardiometabolic disease is present in about 1/3 of American adults right now. Stage C, you've developed the syndrome without end organ damage. Stage D, you have the syndrome with manifestations of end organ damage. And we should think about therapies and prevention according to these stages. Next slide. We also pointed out in this paper the importance of healthcare transformation from our clinical world to more community-based and public health facing and embracing care. Really, health and risk for disease, only about 20% of that or so is determined by the worlds we live in, health systems, but most of that is determined outside of that. Next slide. Well, as we think about improving blood pressure control, cholesterol management, and continuing to focus on cardiovascular disease prevention during this pandemic and beyond, one of our big challenges is therapeutic inertia. So we often talk about medication adherence and compliance, but we need to really focus on making appropriate evidence-based changes in all of our patients, improving their care at each and every visit, and improving their care, importantly, through team-based approaches and systems-based approaches. Next slide. I was an investigator in Berry 2D. If you're not familiar with Berry 2D, this was a randomized controlled clinical trial looking at diabetics with obstructive coronary disease. They were randomized to revascularization at the discretion of their clinician with optimal medical and lifestyle therapy versus OMT and lifestyle therapy. And after 5 years, there was no mortality difference in this population. Next slide. There were about 2,300 people who were participating in Berry 2D. And we looked at 7 different, very straightforward cardiovascular risk markers: smoking, lipid measures, blood pressure, and A1C, much like you all have been doing with the Right Care Initiative. Next slide. And what we demonstrated in this paper in JACC was the most important thing for your diabetics with obstructive coronary disease was not whether you bypass them or put in stents. Press ahead, please. It's actually whether you focus on comprehensive risk factor reduction and achieve comprehensive risk factor reduction. So a real linear relationship between risk factors at goal and risk factors at optimal levels. Next slide. And you can keep going. Next slide. Well, just this week was published in JACC the updated ACC Expert Consensus Decision Pathway on Novel Therapies for Cardiovascular Risk Reduction among people living with type 2 diabetes. This is an extension of the paradigm of cardiovascular risk reduction, and we now have evidence that several classes of agents, the SGLT2 inhibitors and the GLP-1 receptor agonists, not only will improve glycemic control, but actually these agents are moving to the forefront in that these are cardiovascular preventive pharmacotherapies. Next slide. I know many of you have heard of the ischemia trial, which was recently presented and published in the New England Journal of Medicine. David Marin from Stanford was the first author of this paper. And ischemia is the latest of studies, Courage, Berry 2D, and now ischemia. That really points out that when we can deliver optimal medical therapy in concert with optimal lifestyle and behavioral therapy, we see really no additional benefit from many of our patients when we add revascularization strategies. Next slide. I've worked for many years in the space of cardiac rehabilitation. Cardiac rehab is an area that really brings together comprehensive cardiac risk reduction, a team-based approach to care, core components of cardiac rehab. Cardiac rehab is right now a class 1 indication for many of those we care for. Next slide. Cardiac rehab is an effective therapy, reducing total and cardiovascular disease mortality in a dose-dependent fashion. So enrollment in cardiac rehab, participation, high-level participation, completion, and maintenance all have a dose response, reducing hospitalization, angina, depression. As I mentioned, a class 1 recommendation, a quality of care metric, And the future likely will be through home-based delivery, e-health, m-health, and what may be hybrid models. Next slide. In our paper in JACC, we pointed out again that the cardiac rehab of the future must be patient-centered, comprehensive, and delivered through easily accessible models, emphasizing value and healthcare outcomes and cost effectiveness. Next slide. I have been involved in training the future leaders in preventive cardiology now for several decades. As we think about the future of cardiovascular disease prevention and whether preventive cardiology will continue to charge ahead as a subspecialty of cardiovascular medicine, next slide, I think we need to realize that there will always be a limited number of preventive cardiologists, but the future is we need more cardiovascular prevention specialists, cardiometabolic and diabetes care specialists, and population-focused, public health-oriented cardiovascular prevention specialists, which I do think the pandemic is really, really highlighting. Next slide. So what about the post-COVID future? Again, these are my thoughts, but the post-COVID future, we are already seeing it right now. So the future is here. We're seeing an acceleration of new care models, use of telehealth and telemedicine. Hopefully we will see decreased use of ineffective, low-value care in this volume to value transformation. And I do think we'll see continued rapid movement to healthcare integration and consolidation. Next slide. We absolutely need to bring together the sectors of health and healthcare and preventive care delivery. We need to focus more on where we are born, where we live, work, learn, and play. So traditional healthcare, but traditional healthcare better connected to public health, our industry, our workplaces, our communities, our environments. Next slide. So I've learned about some major successes across the country. And so this tells me that cardiovascular disease prevention is possible. The Right Care Initiative, the Be There San Diego program through the University of Best Practices is clearly leading the charge. And I'm actually here today to learn from all of you besides sharing my presentation. Nashville Health, Kaiser of California, the South Carolina Collaborative, and what's happening in the state of Minnesota related to comprehensive risk factor control. Next slide. So what about the future? Will it be precision medicine or will it be population health? The next slide. Well, really, we will have the science to deliver precision medicine, but we will certainly need to think about cost effectiveness. We absolutely have the know-how to do better with population health. A term called precision public health, I think, is an important one, coined by Mew and Curry from the CDC. So precision medicine is providing the right treatment to the right patient at the right time. Precision public health is providing the right intervention to the right population at the right time. Next slide. Here we go. So as mentioned, I have been grateful to be serving in the position as the Executive Director of the Million Hearts Initiative. Today, though, I'm here speaking on behalf of myself. The Million Hearts Initiative, though, Million Hearts 2022, has an ambitious but achievable aim to prevent 1 million heart attacks, strokes, and cardiovascular events in our country through keeping people healthy, optimizing care, and focusing on priority populations. Next slide. So we know through environmental approaches at a population level, reducing sodium intake, tobacco use, increasing physical activity, and then optimizing care, improving those ABCSs, as has been done very well through the initiative, the Right Care Initiative in California, increased use of cardiac rehab, and improving outcome for priority populations. There are many priority populations, but in Million Hearts, we are focusing on African Americans with hypertension, the 35 to 64-year-old age group, because of the data I showed you before, where we're seeing increasing trends in mortality related to heart attack and stroke in younger adults, those who are living with heart disease and a prior stroke, and those with mental health or substance use disorders. Next slide. Well, Million Hearts has been deemed, along with antibiotic resistance, HIV elimination, opioid overdose, vaccine preventable disease, and viral hepatitis, as one of the CDC's winnable battles. This is where the CDC and its partners can make significant progress in a relatively short time period. Next slide. So the post-COVID future. I'm going to make the case that we are paving the way for the future right now, today, at this moment. And so as we think about the challenges before us, there are opportunities. We definitely want to increase the use of clinical preventive services. This is a great paper by Auerbach talking about the 3 buckets of prevention. We definitely want to implement interventions that reach whole populations. And then we want to be able to provide services extending care outside of our clinical setting. Next slide. So let's go back to epidemics and pandemics, remembering that cardiovascular disease is a global epidemic. And so in order to address these epidemics of cardiovascular disease, cardiometabolic risk, obesity, and diabetes, we need to identify the vectors and causes, identify barriers, roadblocks, and factors that propagate them. And our ultimate goal should be, just like with any other epidemic, control, elimination, and eventually eradication. The next slide. So the post-COVID future of cardiovascular prevention, we know we're in the present right now. COVID impacts the cardiovascular system. It is clearly impacting cardiovascular care and cardiovascular outcomes. But as I pointed out, cardiovascular health and cardiovascular disease prevention must remain a priority in the midst of this pandemic. The future definitely is a greater need for integration of healthcare and public health at the level of the community. Next slide. So this is what I hope the Cardiovascular Disease Prevention Center of the future will look like. And I even hope that those in this center will be working at treadmill workstations or pedal workstations as opposed to sitting. These will be population approaches. So we'll be looking up at the dashboard on the wall. The green population will be celebrating. The red population, that's the population that needs our most intensive efforts. And the yellow population that will want to move into the green zone. Next slide. I'm originally from New York. And so I'm going to start my conclusions here with a yogiism. Yogi Berra, who was the catcher of the New York Yankees, said, "It's tough to make predictions, especially about the future. What we want to do, though, is not predict the future. What we want to do is we want to make the future. Things won't happen by themselves. We need to make them happen through our partnership and collaboration." The next slide. So in January of 2020, I had a wonderful visit with those from the Right Care Initiative in California. Tony Demaria on the left. Thank you to all of you really for your support, your partnership. And I look forward to when I can visit California again, not virtually, but really I want to be able to visit with all of you and enjoy our company real time. So thank you for inviting me today. I'm glad to address questions or comments. And I look forward to the rest of the meeting. As I said, I'm here to learn from all of you. And I look forward to the rest of the meeting. Thank you again.
Thank you, Dr. Sperling. We have many leaders from around the state who would like to be unmuted, particularly the panelists, to ask questions. And Dr. Bommer is going to be leading the Q&A. Dr. Bommer, you are muted. Times have really changed since we hosted you here in California, and we're just so thrilled that we had the time to meet over several days in Southern California back before we had the pandemic on the loose. So really appreciate your fitting us in between your COVID-19 heart patients, Dr. Sperling, and all the rest of the cardiologists that are on the phone that are working night and day.
Well, grateful for my visit back in January, again, for the chance to be with all of you here today. And I really want to, again, extend my thanks out to all of you who are focusing on the importance of cardiovascular disease prevention at this time when we have challenges that we have never encountered before.
So Larry, there's a couple of questions that I'll let you deal with. They actually relate to finances, and are we in trouble now trying to implement our prevention in the setting of the current struggle for survival with COVID? So we've had in the past, let's say, economic analyses of our prevention. And obviously, prevention is probably one of the cheapest ways to reduce cardiovascular disease. Is there any change in that now that we also have COVID? Because obviously, that changes our interaction. We can't come in and see the patient as often. We're going to be more telehealth. Does that have a positive or negative aspect for finances?
Yeah, so a very important question. I will qualify that as I'm not a healthcare economics specialist by any means, but I know right now healthcare systems are very concerned economically, you know, in terms of the shutdowns that have occurred and patients that are fearful of coming into emergency rooms or even to the clinics. But I think this is a great opportunity to learn and a great opportunity to really think about the return on investments. Prevention, we know prevention will return on the investment. And right now, there's gonna be another speaker today that I can't wait to hear about, a proactive and preemptive systems approach to thinking about the care of our populations, as opposed to just waiting for somebody to come into the ER or the clinic or to set up a telemedicine visit with me or send me a portal message. So I think we can be proactive, we can be strategic, and I think that telemedicine is here to stay, and this should be an opportunity that we should embrace, not just from a healthcare economic standpoint, but from a patient care standpoint, really extending our ability as a care team to do things that we will be able to do forevermore in medicine. So I look at this as a really exciting time, and I hope the economics will bear that.
Thank you. Yeah, we do have evidence, fortunately, both our blood pressure control and our cholesterol control. The majority of patients can be controlled with generic medicines, and so the cost is really low. And we do have studies that have been done that show that generic medicines for blood pressure control and cholesterol control actually save money because they save hospitalizations, both for primary care, that is high-risk individuals with primary prevention, as well as obviously in secondary prevention, people who already have existing cardiovascular disease or events, very effective financially in those individuals as well. There's another trend of questions that I have on chat related to okay, if you think California is leading the curve, the big challenge is how do we stay ahead of the curve? Is there any recommendations you would make for California? And I would point out that in California, what we've seen is Southern California has done actually better than Northern California. Is there some recommendation you would make for Southern California to stay ahead of the curve in prevention?
Yeah, I think right now, staying ahead of the curve in the middle of the pandemic, it comes back to one of the main points I tried to emphasize a few times. It's that we need to make prevention a priority, cardiovascular disease prevention a priority right now. And really, for those living with serious health conditions, which include cardiovascular diseases and diabetes and obesity, there's never been a more important time ever than focusing on optimal prevention. And so staying ahead of the curve right now is sticking with your game plan, but at the same time, it's thinking out of the box and maybe deploying your care team in different ways, utilizing the ability of virtual platforms, utilizing population health approaches to have strategic responses, and thinking about right now those at highest risk as our top priorities.
That's great. Another question on our Q&A is related to employers. Obviously, hopefully a number of people are still employed in the country today, and their employers are paying for healthcare, and they might be incentivized to promote preventive cardiology to reduce complications in their patients, that is their employees, and to keep those employees on long-term in good health so that they would be very productive. Is there anything that we could throw out or offer to employer groups, or that has been successful for employer groups, for things like control of blood pressure, control of weight loss, exercise incentives? Are those working for the employer?
We know that employers that are committed to the health of their employees see returns on those investments. They see less days of work missed, greater presenteeism, which means, people who are at work are working at their capacity. And I do think that right now, those of us who are employed should be very grateful. Each and every one of us in our work settings can be a prevention champion. So you in your local environment, and remember, I said health is local and risk for disease is also local. And so wherever you are and wherever you work, you can be a prevention champion. You can set an example in your workspace for others. If you're a manager, you can actually incentivize or give your employees time for physical activity and health-related behaviors. And it's all about walking the talk. So I do think employers are very, very central to maximizing our capabilities to deliver cardiovascular prevention in populations.
So I do want to say that we have our schedule is that we'll now hear from an amazing prevention program being put together through the National Medical Association in collaboration with several other groups. I won't try to describe it. I'll allow our Los Angeles chair, Dr. Carol Zaher of HealthNet, to introduce Dr. Oliver Brooks, who's a wonderful champion for improving care. And thank you so much, Dr. Sperling, for staying with us, because Dr. Demaria will be facilitating further Q&A after Dr. Brooks finishes his presentation. Really appreciate your being with us.
Thank you, Hattie. Yeah, thank you, Dr. Sperling. Great talk, and I think we'll have more discussion later on in the program because there are a lot of questions that folks have. It gives me great pleasure to introduce our next speaker, Dr. Oliver Brooks, who certainly has credentials and a sphere of influence that encompasses both the national geography as well as the local. So Dr. Brooks is the medical director of Watts Healthcare, the Chief Medical Officer of the LA Care Health Plan, Chair of the Community Clinic Association of LA County, and the recent President of National Medical Association. So quite a distinguished background, Dr. Brooks. And he's going to talk to us on what I think is an intriguing title to the program, with the National Medical Association's Release the Pressure Hypertension Program. Dr. Brooks, thank you.
Thank you very much. Thank you, Carol. First want to note, okay, I have no disclosures in terms of industry. I will say I am speaking as immediate past president of the National Medical Association. So the words I represent, the words I speak do represent the position of the National Medical Association related to this program. A few quick statements. Dr. Sperling, that was just an excellent presentation. They teach you when you're giving talks like this to have your camera at eye level. So to prop up my computer, it's sitting on two books, Nelson's textbook of pediatrics. I'm a pediatrician, and it's sitting on Heeres, The Heart. So definitely well respected. I actually have been to American College of Cardiology's headquarters down on M Street. I went with the representing the NMA, looking at to increase the number of African-American cardiologists. So I appreciate the work that the American College of Cardiology is doing and the work that you're doing. And I will also say, as one who's into immunizations, that statement of 6 times the rate of MIs within a week of getting influenza, and influenza, this being one of the most important years in terms of getting people vaccinated. You made many points, but I noted those particular points that you made, and I really appreciate that. So I'm going to go on into my presentation. I am past president of the National Medical Association, and we represent the 50,000 African-American physicians in the country and the African-American community. And so this is very important as it relates to cardiovascular disease. Dr. Sperling also mentioned social determinants of health, and those are as important as these other measures. So I do appreciate him stating that. So what is the Release the Pressure campaign? Next slide. So Release the Pressure, it brings together a diverse coalition of healthcare organizations. Basically, in January, February, we had a conference call with the Center for Health Equity of the AMA. The past president of the AMA, Dr. Patrice Harris, was the first African-American woman to be president of the AMA. She started the Center for Health Equity. So working with the AMA, it's like, what can we do working together to address outcomes? We had first talked about diabetes, but then we settled on hypertension. And I just find that fascinating with the university best practices, controlling your blood sugar, controlling your cholesterol, and controlling your BP. So we did find one of those 3 that is a focus of the best practice. With COVID-19 and with the police brutality on March 25th with George Floyd, that kind of threw a lot of our things off. We had this focus, but then with COVID-19 and hypertension being one of the noted underlying conditions that could lead to more adverse outcomes, it was just like prescient at the same time that we were doing this. So the mission of the Release the Pressure Coalition is to partner with Black women to take preventive action. You kept saying the word preventive action to eliminate hypertension, and therefore reduce the chance of heart attack and stroke. Next. So the 6 partners in this Release the Pressure campaign, the AMA Foundation, American College of Association of Black Cardiologists, Minority Health Institute, National Medical Association, all came together and met in March in Atlanta, Dr. Sperling's living quarters or living city now. And we put this program together to address down on the ground how to get African-American women to reduce their blood pressure. Next. So why? You all know this is preached to the choir, but high blood pressure is 36% higher in Black women as opposed to white women. Prevalence of high blood pressure in African-American adults is among the highest in the world, not the nation, in the world. And Black women are 10% less likely to be controlled than white women. Only 3 million or 20% of African-American adults with hypertension are controlled to their goal. So it was therefore determined that this would be a good approach, i.e. controlling, preventing heart disease by reducing blood pressure. Next slide. Okay, so the goal, no, go back one. Right, so the goal is to have African-American women take the pledge. The pledge is to know your numbers, talk with your doctor and bring your squad. The goal over 1 year, this started supposed to jump off in late March. 300,000 African-American women take the pledge. 75,000 complete the self-measurement blood pressure training videos, which is on the website once you take the pledge, and begin to track their blood pressure measurements by self-management. And then 40,000 have a virtual physician engagement. Join in some virtual event that's on the Release the Pressure Coalition platform. Next slide. So this is the pledge, and it seems very basic, but we feel that by you just committing to something and being able to have this as a document you could print once you take the pledge, you pledge to set a blood pressure goal with a healthcare professional, monitor your blood pressure at home, activate a wellness plan, and check in with their squad. So the basic concepts are these four. So connect with your doctor to determine, have an understanding of where you want to be in terms of your BP. Monitor it, and either that you either are there or are not there. And then the concept of wellness. Dr. Sperling mentioned that COVID-19 likes an unwell host. So wellness is critical. And then check in with your squad. So what that means is once you take the pledge, bring in others, bring in your girlfriends, bring in your family, bring in your coworkers to also take the pledge and work together, because we have learned that when you have shared goals, you're more likely to achieve them. Next slide. So breaking down the goals. So how do you do self-measured or self-managed blood pressure? So on the website, so you go to essence.com/release the pressure. So it's a landing page, if you will. There's a video that shows you how to take your blood pressure. And it's very deliberate. Find a quiet place, don't cough, take it more than once, do it morning and evening, and then log it. So again, a strong focus on self-management. Again, the concept of taking control of your own health. Next slide. So again, part of it is also to be in attendance at a virtual event. This particular slide was one where we had on the top left, I can't remember her name. She was one of the wellness coordinators when we had a virtual meeting like this. The middle is the chairman of the board of NMA. To the right is the immediate past president of the AMA, and the other three are just other people involved. So we plan to have these virtual events where you are in attendance, and that's part of your pledge, where you learn more about cardiovascular disease and wellness. Next slide. Okay, so this program is funded by the AMA Foundation. So the AMA has committed. It's a 3-year project. We, the NMA, have signed an MOU for 1 year, and then it will be renewed for years 2 and 3. And what has happened is the plan hired Essence Magazine. Essence Magazine is the #1 African-American print magazine, and definitely for African-American women. So Essence is a partner, but they're a partner that has been hired. And there's a group called Converge that is the consultant to help run the program. So they bring the AMA, the AHA, the NMA, Association of Black Cardiologists, Minority Health Institute together and put a structure in to roll out this campaign. Next slide. So what you see on the left is the landing page. So if you go to essence.com, release the pressure, this is where it takes you. So if you click on the red, take the pledge, it'll take you to that slide that I showed you before. You would type your name in, and so you take the pledge, and then you actually get emailed the actual pledge itself. Upper right is these are videos. If you check on each one of these, it gives you information, and it's really, I can't see it as well because let me go to full screen. Okay, so setting a goal with your doctor, monitoring your blood pressure at home, activating wellness, and then checking with your squad. So as it relates to the wellness, there are 4 videos that demonstrate the focus. So the focus is on salt intake reduction, general healthy eating, reduction in stress, and exercise. And again, we get back around to prevention. And I kind of want to emphasize the stress as it relates to cardiovascular health, because there are studies that document that African Americans have higher rates of cardiovascular disease and felt to be related to cumulative stress over decades from racism. So with the allostatic pressure from chronic release of cortisol, you see injury to the endothelium. So stress reduction is very important to me. That aspect of the wellness, I really do focus on. Obviously, the other 3 are also important, but that one I find is somewhat overlooked. Next slide. So these are media assets. So once we get the program up and running as we have, these are Instagram and Facebook stories that can be sent out to the women who took the pledge, and they get this pledge completion chart, as I said. And as we move through this presentation, there are other uses for social media, because we have determined that reaching the population through social media is probably the single most important area upon which to focus, because that's where the focus is. And also Dr. Sperling mentioned about the age where younger individuals are showing cardiovascular disease. And we feel that this focus will end up being more likely on a younger demographic. So it's interesting that that was a decision that was made just out of the whole flow of what we were doing, but Dr. Sperling's data is showing how appropriate this approach is. Next slide. So in terms of digital media, so this is on essence.com's homepage. There was an article that was written about this, and it's bringing in. So this is again part of the rollout, if you will, of the Release the Pressure campaign. Next slide. So there's a podcast. This again is the immediate past president of the AMA, Dr. Patrice Heeres. And This was a podcast where she spoke about the importance of healthy habits, the importance of controlling your blood pressure, and how it is especially relevant to African-American women. Next slide. So in terms of other media assets, this is connecting to your quote unquote squad. So again, when you're working to get your blood pressure under control, you're measuring your blood pressure. The measurement you got this afternoon or yesterday afternoon was a little high. Contact your squad and just talk to them and say, maybe you're under stress, you're not eating right. So just helping people connect. And then we considered ourselves a squad, those partners, AMA, AHA, Minority Health Institute, Association of Black Cardiologists. So we are sending out information and we feel it's important that it is a joint statement. The goals, I will say, for blood pressure are the goals that are adopted or I guess developed by the American Heart Association. Less than 120 and less than 80 is under control, 121 to 129, and less than 80 is moderate and elevated, excuse me. And then hypertension is greater than or equal to 130 or greater than or equal to 90. So we have the same goals in alignment with the American Heart Association and felt that was important in terms of just having these major organizations working together. So from our squad to your squad, this is showing exercise, check in with your doctor, set your BP goals. So it's going through the pledges. Next slide. So Essence Magazine has a wellness house at their annual festival. So what we did is it was a soft launch on March, feels like it was like March 1st in Atlanta, and brought together, there were 500 women that were part of this wellness house. And part of the wellness house was taking the pledge, to talk with the doctor if you had questions, and there were lectures all through the day. I look back on this somewhat wistfully, in fact, in the fact that there were 500 people in one room. And I was, in fact, speaking to the president of the AMA, and she was coming out to California in 2 weeks. And so I'll see you in 2 weeks. She said, well, I don't know, there's this COVID thing. We may not even be able to travel. And within 2 weeks, the whole country shut down. The Wellness House had 500 people. Essence Magazine has a yearly Essence Festival in New Orleans where upwards of 500,000 individuals present. So we had planned a wellness house separate from their whole convention. And that was where we felt that we could get this great launch where we could get the 300,000 to take the pledge, the 75,000 to view the videos, and 40,000 to connect with their physicians. So these are just some pictures from our soft opening of a wellness house. Next slide. So this, again, the plan was to be at Essence Festival, and we were unable to do that. Have 500,000 people in New Orleans, not happening. Next slide. So next slide. So we did get some press, National Medical News printed an article about what we were trying to do. And then I had an article in CNBC. I was on Bertha Coons, also on CNBC. We were discussing the racial disparities of health and talking about how those disparities, which was elucidated very well by Dr. Sperling, do lead to more adverse outcomes for the African-American community. Next slide. Next. All right, so what we're doing right now is we're working to push our project forward. So this is a basic structure. This is what goes out to all the partners. So like in September, for example, ongoing integration with Essence, native articles, which means articles that are in the print version, and digital and social media. The messaging for September would make a plan with the healthcare professional. and then building and working our collaboration. So we just got together in March, those organizations. So we're still building on our collaboration. It's a 3-year project, so we're amplifying each other. October, for example, let's see, World Hypertension Day, so there would be a focus on that. And that month would be managing your blood pressure at home. November would be checking in with your squad, so focus on those people that are around you. Don't even worry about your blood pressure as much, but make sure that it says your mother and your best friend and the neighbor across the street, that's your squad. How are you all doing? So this has been laid out through February. It's loose. In other words, if my particular organization wants to focus on another aspect of it, obviously I have the ability to do that. And this goes out through February. And we meet on a monthly basis, discuss where we are, and then move forward. Next slide. So, and then next slide. So this is how can a healthcare provider get involved in the release the pressure? So practice what you preach, which is taking a pledge, email, share messages with your squad, giveaway, custom virtual events. Next slide. So take the pledge, and this just discusses it, and then start messaging your patients. So we want physicians, healthcare providers to actually get involved with this and start to track their own blood pressure. And then when you're doing it yourself, you can teach it better. Next slide. So email messages, professional networks, share within your professional networks and your personal networks. So again, this is as physicians, when you engage, you get your patients and others to engage. Next slide. And then social media. So these are 1, 2, 3, 4, 5 links that go to social media graphics that, again, as a healthcare professional, you can disseminate through your network. Next slide. And more sample posts, Twitter and Instagram. Next slide. Okay, and then develop helpful products are the things that you can develop yourself, videos, materials, written materials, blood pressure cuffs, sustain heart health, weight management tools. Advocate, for example, like in California, Medi-Cal will pay for automated home blood pressure monitors. So get that information out. Next slide. And then partner with the Release the Pressure Squad. So reach out via Facebook, Instagram, Zoom, have meetings with influencers, try to just spread the word in whatever manner you find works best for you. Next slide. So that's the program in a nutshell. It's still building. Again, COVID-19 affected us greatly by not having it to present to 500,000 individuals in July, but we are moving forward with monthly meetings and rolling out the program. So I will stop there.
What a beautiful program.
Thank you.
It's amazing, amazing work. Beautiful collaborative work, and we're so pleased that you could be with us today.
My pleasure. And I believe I am open to questions, and I would like to introduce our facilitator for questioning, as Dr. mentioned before, Dr. Anthony Demaria, who is the Judith White Chair in Cardiology at UC San Diego School of Medicine. Now, Be There San Diego co-founder and chairman, founding co-chair of the Right Care Initiative of Best Practices in San Diego, subsequently named Be There San Diego. And he's done so much. He's the former editor-in-chief, Journal of American Cardiology, and founding director of Sulpicio Family Cardiovascular Center at UCSD. He's an expert in the cause, diagnosis, and treatment of heart disease in general, and specifically in state-of-the-art diagnostics such as ultrasound and cardiac imaging. His research focus is the improvement of non-invasive imaging technologies. He has published widely on this topic, along with being the immediate past editor-in-chief of JACC. He is past and youngest ever president of the American College of Cardiology and the American Society of Echocardiography. Dr. Demaria is the former host of Cardiology Update on Lifetime Television. So he's a television star, He has authored or co-authored more than 350 articles for medical journals and various professional papers in areas of non-invasive techniques, pharmacology, acute MI, and exercise. He also has served on the editorial board of every major cardiology journal and continues to make seminal contributions toward understanding of cardiac physiology. Dr. Demaria, welcome. You might be muted.
Sorry, yeah.
There you go.
Thank you very much for that introduction. That was amazing. If I ever need a press agent, I hope you're available part-time anyway. I am pleased to be here. I've worked with Hattie and the Right Care Initiative for a whole lot of years, and we continue, I think, to make progress in reducing heart attacks and strokes, so that at the moment, I'm not sure what everyone is seeing, but if you, I'm seeing, okay, I'm seeing just about.
We are seeing you, Tony. We are so
Okay.
pleased to be seeing you. Thank you for joining us from San Diego.
Sure. So, you know, reflecting back on the presentations, it's hard to follow Larry Sperling. Actually, I remember taking a course recently in how to give a very excellent presentation, and there were three principles. One principle was to be sure that you cover all of the information, and the second principle was to be sure that you don't go over time, and the third principle to give a very well received presentation was to never ever follow Larry Sperling. Unfortunately, I find myself in that situation. But if we reflect, I've been asked to make a few comments, and then we have a panel to talk about what we've heard. I'm impressed that in terms of preventive cardiology in the future after COVID, that we're probably going to be dealing with COVID for a long time based on the data that's appearing about persistent abnormalities long after recovery of illness. And the concept, at least in cardiovascular disease, that if we get some of the allegedly 5 million people who've had COVID, many of them may well be at risk of developing cardiovascular abnormalities. We certainly have to move on that. And I can envision in the future that we may well be saying, in addition to the ABCs that we heard about earlier, what is your COVID status? Were you ever positive? Do you have antibodies? And how should we act upon that if you do? We may be incorporating our COVID experience into preventive cardiology for a long time to come. So let me ask Dr. Sky, what did you take away that was unique from the presentations that we just heard?
I think the most important thing that stood out for me is in Dr. Sperling's slide, where he had the pyramid with the hierarchy of procedures at the top, traditionally paying the best, and yet the compelling evidence in his talk, as well as the blood pressure presentation, that prevention really should be, at least from what is best, not a monetary, should be at the top of that pyramid. I'm optimistic that there will be a reset in our priorities as our hospitals recover. And I'd like to know if anyone else has any thoughts on that possible reset in our prioritization of money versus what should be done.
Well, that would be wonderful if there is. I've been doing this for a few years, as you can see from my gray hair, and we have talked about that reset for almost as long as I've been in medicine. And hope springs eternal, and we'll cross our fingers. Yeah. But I'm not sure. I know maybe Scott Flinn, who's of course one of the individuals involved in deciding what we cover and how we cover it, may have some ideas. Scott, what do you think?
It's always been difficult finding a way to justify the ROI for prevention and how far out that is. And as folks have alluded to on this talk, I'm wondering if we're maybe turning the corner a little bit out that. Larry, I would certainly echo what you said about the cardiovascular prevention priority is right now. That is my take-home message from that. And Oliver, I like what you had about it seemed like a practical way to actually introduce some of this stuff. So let's hope that we're turning that corner, Tony, and people will pay attention to the prevention part. And you know, if there's an ROI, it makes easy sense for us to be able to do the right thing. It's figuring out how to make that work and really make those numbers come out right. I just want to give a personal aside.
I just want to chime in and say that the ROI has been published in 2 national journals showing very significant financial savings from the formula that Dr. Demaria and you and others on the phone have helped us to develop and drive, which is get that LDL less than 100, preferably less than 70, or Tony, how do you say it? You don't want to be the smartest person in the graveyard, get your LDL less than 70. He said that at every single meeting, which helped drive those statistics behind my head. So the published papers show 86 million in savings and 3,825 fewer acute myocardial infarction hospitalizations than anticipated prior to us driving those metrics. So sorry to interrupt you, Scott.
Right, and the key always is whose money is that you're saving, and how do you get them to pay for the ROI, and that's where it always comes back to. Just 2 other things. One, a personal anecdote. I absolutely have seen the delay in folks seeking care. I was working in urgent care a couple weeks ago, and I had a guy come in at about 2:30, 52-year-old male with severe substernal crushing chest pain. And he woke up with it and went to work at 8 and came home at 10 because he didn't feel good still and tried to sleep it off and didn't come in until 2:30 because he was afraid of catching COVID. So it's real, it's out there, seeing it myself. The other hopeful thing that maybe there'll be some synergy of all these forces coming together is many of you are aware that the CDC and the Surgeon General's office are putting together a national hypertension roundtable, and there'll soon be a call to action coming from the Surgeon General for hypertension control. So again, hopefully a lot of forces acting together in big ways, and we can get this ball moving forward even faster.
Yeah. When it's all said and done, Scott, we've got the healthcare team on this call, on this Zoom, but it's the individual patient, the individual that's not even a patient yet, who's got to take the responsibility. We're all out there and we're trying to incentivize people to lower their blood pressure, to join the squad, etc. But until the patients themselves, until society itself joins us in this effort, it's going to be hard to push those goals to 100% of blood pressure and cholesterol and whatever that Bill Bommer alluded to at the very beginning of this meeting. So, Bill?
Tony, I would agree with you 100% on, let me just chime in on that. That is one of the holy grails is patient activation, and probably one of the toughest things we do. And historically, as providers, we have only worked on the patient in front of us. It's not necessarily the patient in front of us that we have to work the hardest on. It's the one who won't come in, the one who's not paying attention. And getting those patients activated, you know, when you think about it, their national hypertension control is what, less than 50%, 48%, something like that. And you're considered at the 90th percentile when you have an 80% control, 99th percentile. So a lot of work to do. How do we get the patients engaged, activated, and get them as part of the solution here? I agree with you 100% on that, Tony.
Tony, I have a quick question. Can you hear me?
I can.
Okay, so following the tweets and the social media that we have on this Zoom call, there are two questions that came up and I thought it would be addressed. One for Dr. Sperling is, we all acknowledge secondary prevention, the use of ABC. Aspirin is certainly recommended. How about for primary prevention? The question was, for a geriatric patient who has no other risk factors other than age, would you still recommend aspirin 81 milligrams for everyone? Or are there groups or ethnicities that you would make that recommendation? And then the other question is for Dr. Brooks. Great presentation. Are you an expert in social media? You've done such a great job. Or, and this was from Jessica Nunez de Ibarra, who is our CDPH person in California. Would you recommend, or do you have a professional consultant to allow you to get this social media information out to the population to do the most good?
I guess you go first, Dr. Sperling.
Larry?
Yeah, I'm unmuting there.
Okay.
Okay.
The aspirin for primary prevention question is one that I think we first of all, we scratch our head. We should be humbled here as well, because aspirin is the oldest pharmacotherapy known to mankind from the bark of the willow tree. What we do know is if we look at the ACC/AHA guidelines for primary prevention, which were presented at ACC not last year, but the year before and published, we certainly call into question using aspirin for primary prevention across the population. We need to think about net clinical benefit. For every medicine, there's benefits, risks, and side effects, and the risks of aspirin are bleeding, of course. What we should think about, though, is shared decision-making. And there were 3 large clinical trials that really, one in diabetics, one in elderly people, and one in kind of adults, that called this into question. In the diabetics, there was still benefit from aspirin, but risk of bleeding. And so here it comes back to an individual discussion with your patient after you assess their risk for cardiovascular event. Those above a 10-year ASCVD risk of 10%, they are individuals who might benefit from an aspirin if their bleeding risk is low. But you should discuss this. And I think right now there's no right answer. There is an aspirin calculator that you can refer to. We published a paper in the American Journal of Cardiology last year, first author Thobani, Anisha, addressing this.
Thank you.
So as it relates to the question to me, yes, no, I have children, first of all. That helps a lot with the social media part of it. We hired a consultant called Converge to put the program together, and that's who's working with the social media. And what we're developing now is called a physician toolkit. So that toolkit will have the information and the guidance, if you will, to have a social media presence as it relates to your particular practice.
Thank you.
At this stage, let me turn it back to Hattie to introduce Cindy, if she will.
We have such an amazing team with us today, and Cindy Jambroni has been with the Right Care Initiative since 2008 through multiple jobs. She first came to us through similar family experience to mine, and she co-leads our heart failure work group across the state. She works for Memorial Care, which is one of the largest health systems in Southern California, and she brought to our attention a wonderful program that has been developed on steroids during COVID-19 to do proactive outreach to the highest risk people. So thank you, Cindy, for being with us today and for all your dedication to the Right Care Initiative.
Thank you, Hattie. I appreciate the lovely introduction. And it is now my pleasure to introduce my colleague, Linda Violas. Linda serves as the Executive Director of our ACOs for Memorial Care in Orange and Los Angeles County. During the COVID-19 pandemic, she's led a special outreach project to high-risk patients utilizing Memorial Care's robust data warehouse. Ms. Violas has an extensive background in data analysis and reporting related to utilization, patient care, and quality management. Prior to her tenure at Memorial Care, she served as Director of Clinical Effectiveness for St. Joseph's Health. She received her nursing education from the University of Iowa. And with that, I'll turn it over to Linda.
Thank you, Cindy. Can you hear me, or am I muted?
No, you're perfect. Thank you.
Oh, wonderful, wonderful. Well, I know I need to do a time check because I realized we're a little past, so I will do the best I can with the time here. But do you want to allow sometimes for discussion and questions, because I can see this is a very inquisitive group. So I've been asked today to talk about the COVID-19 risk of mortality algorithm, and more than that, how we took this algorithm and applied it. And my goal today in being asked to speak is to be transparent and honest with what worked, what didn't. The time we had, we realized it wasn't perfect, but we put it all in effort. And I want to acknowledge a couple colleagues who have been listening in and may join me with any questions that perhaps they're better equipped to respond to. First is Gwen Mertz. She's the Director of Care Management. She's my colleague in medical management, and she's over the HMO lives. And then I'm over the ACO lives. And then I have Dr. Mike Randhawa, and he is our data scientist, and he is the one responsible for the algorithm, and we work hand in hand with him. And it's just been a pleasure to have all this support to get this through. So go to next slide, please. So I want to just do a brief outline. I'd like to frame who Memorial Care is, where we sit in the state, how we work. Then I'd like to spend a lot of time on the mortality algorithm. I want to talk to you about the challenge that Gwen and I were given as we were given the ability to have all this data to work with. I wanted to give a playbook. I realize there's many different backgrounds and clinical practice settings, so can you take this and make this work for your setting? That would totally be my goal here. So I'll have that for you. And then what did we accomplish? We put this together quickly. We wanted to make an impact. It was all hands on deck, but what did we really get through? So I'd like to show you that as well. Next slide, please. So just a little bit about Memorial Care. This is my first time speaking with the group, so perhaps some of you are quite familiar. We are a healthcare delivery system that's located on the Pacific Coast in Southern California, and we really hug the 405 freeway. So we go all the way down to Southern Orange County, up into LA County, about as far north as Long Beach and Torrance. So we have 4 award-winning hospitals. One of them is a designated children's hospital. The other 3 are for adults. We have 30 health centers. These health centers are a medical group formation where we have several practices together and other type diagnostic deliveries so that when a person comes into our site, they can get everything done. Our other primary physician care that makes up our network are independent practice called Greater Newport Physicians. So we have 260 of those. And then we have several joint ventures. And this part is what really enables us to spread out and have a very vast delivery to our members and to our clients. So we have a joint venture for ambulatory imaging centers. We have ambulatory surgical centers. We have multiple urgent care centers sprinkled throughout our service area. And then the other joint venture is for dialysis, both community-based dialysis centers as well as having home-based dialysis centers. And through the hospitals and through our physician practice base, I'm told it's about 1.7 million patients per year that we touch. Those are a mixed payer source. And then we have about 14,000 employees. Included in there is our employed physicians in the group model. And you're looking at our Huntington Beach site here. Go to the next slide, please. So the big question is, why would you go about risk stratifying? How is this really going to help you identifying who's at the highest risk of mortality? And we practice population health at Memorial Care. Very, very strong here. So when you are going to be doing some risk stratification, if you have the data, this is going to enable you to get your arms around your patient population. And should an outbreak, like we're suffering right now with the pandemic, where are your hotspots? Where should you be really focusing your attention so that you can get maximum delivery of information, assessment of how this population is doing, and yet we want everyone to stay at home, right? We have a stay-at-home order, so we have a lot of challenges here, but we really believe that we needed help. And it was an all hands on deck about mid-March when our governor ordered us to stay at home, and the executive team had said, what can we do to help in this pandemic? So Dr. Mike went to work with our data platform, Health Catalyst, and they put together an algorithm for us. And what we found out was it really gave us an amazing platform to deliver information by having this venue to go out and reach out to these patients. Let's go to the next one. So what were the data parameters? And now I'm talking about what goes into this algorithm so that we can have a really rich data source. So we do in the, this is going to be for both of our HMO and our ACO environments. And we deal with a lot of administrative claims. They're very rich sources of information, as well as our encounter, enrollment data, utilization data. And then we're also able to pull in our electronic health records. So Epic is a big one for us, NextGen's another one, and they're both very rich so that we can have a lot of information to provide analytics and really distill who we should be working through. Now, as far as the time frame of what we were analyzing, somewhat variable because of the different markers that come in that are part of the algorithm. So it's not just this data that we put in, but we put in a layering system that will screen these different patients or bucket them into the categories so that we can discern which ones are at the highest risk. And once again, the population here was our the populations that we have financial risk in, and we have a lot of information through those data sources. Go to the next one. So with the methodology of this, I've noticed that the CDC has been mentioned many times today, and certainly Dr. Randhawa is a consultant for CDC and had a lot of knowledge that he was able to put his fingertips to, but also the World Health Organization and then the United Kingdom's National Health Service. All of these had very robust information and recommendations that we could tap into rather quickly. You just had to have the tools and the vision to put it all together. The next slide, please. So when we were looking at this, there's really three large buckets of a population. So if you think of a pyramid and you think of the very top of that pyramid, and usually the smallest subset of the population is the extremely high risk of mortality. So we had that grouping. Then we had a grouping right underneath them, which was like the middle part of that pyramid. And that was our high risk members. And then the last one were the low risk. And thank goodness on both populations, that was by and far the largest amount of patients that we have. And I'll give you some data snapshots in a minute. But I wanted to go through first just to tell you at a high level, who is categorized into this extremely high risk of mortality. And really what it is if they do get the COVID exposure and then they get the disease, they are going to do probably very poorly, because of already a lot of challenges in health that they're carrying. So the first category that we have are those folks that have had an organ transplant, and they are taking medications to suppress their immune system to maintain their transplant, and those folks are going to be at extremely high risk. The next section would be patients with a cancer diagnosis, and those particularly that are receiving chemotherapy right now. This is their stage of treatment, or they're getting radiation therapy. So these patients, again, we want to single out. Now, in the case of the blood or the bone marrow cancers, your leukemia, lymphoma, myeloma, these, any stage of treatment will qualify you to be at extremely high risk of mortality. The next section, as we started the conversation today about you saying that this was a respiratory kind of transmission, what everybody was worried about, well, yes, that is a problem. If you have cystic fibrosis, if you have severe asthma that requires admission to hospital, treatment with corticosteroids, you again are going to fall into this extremely high risk of mortality. And then lastly, those that have severe disease of body systems, like your renal failure, folks that are on dialysis, these people are definitely going to need to be notified. And because of sheer numbers, when we looked at extremely high risk, this was the population that we put a lot of time and energy in the short time we had to get this up and off the ground. Go to the next slide, please. For the high risk of mortality, this is a bigger bucket. And so we're going to start crossing into different sections of the population. First off, anyone that's 70 or over 70, regardless of your medical condition, you are going to be at high risk. So we're no longer in the extremely high risk, we're in the middle bracket, but still, this is a risk area that if I were in this risk area, I would really want to protect myself. And those were some of the messages that we put out there. Now, for those that are under 70 but have underlying health conditions, you will also fall into this bracket with long-term disease of many kind. And we've already spoke a little bit about respiratory, lung disease, asthma, COPD. But the other one here, which I know is near and dear to this consortium, is the heart disease. So if you have heart failure, if you have this kind of thing, you are definitely going to harbor that risk. Once again, the chronic kidney disease, and then long-term liver disease, hepatitis B and C, and diabetes. This one, diabetes, will put you in a bracket almost any time. And once again, these can be younger people that have these ailments, juvenile onset diabetic, etc. Long-term neurological conditions like Parkinson's, motor neuron disease, multiple sclerosis, cerebral palsy, and even a learning disability could put you in this high bracket. Those that have a spleen disorder, they have sickle cell anemia, they've had a splenectomy, you again will be in our high risk area. And then lastly, our weakened immune system, either because of a medical condition like HIV or AIDS, but also as a result of receiving treatments like corticosteroids and chemotherapy. I've heard a lot in the talks today about obesity as being something that puts you at risk. And in this case, yes, if you have a BMI of 40 or more, you are classified as severely obese, you also, regardless of age, will fall into this high risk of mortality. And then we have the pregnant women. Pregnant women, once again, they're studying this a lot. I've seen that, if they do get the disease, it can be quite devastating. And then not to mention what could happen to the unborn, which is still kind of out there. So these buckets, we wanted to address those entire populations, but we really had to look at some logistics here and the staffing, et cetera, that we have. So I'm going to get into now just defining our ACO population with the next slide. We have about 62,000 lives, and when the numbers were run through the algorithm, we had about 1% of our population. So I want to explain something here. Our ACO population does not have any senior lives in it. It is entirely commercial lives. They are PPO lives in our organization. So we're covering their dependents and the people that are getting their, their coverage through their employment. So 1% sounded pretty good. We looked at 348 patients and thought we absolutely should be able to have a campaign to touch these patients. The next bracket gave us a little heartburn. These patients have high risk. We have quite a few of them here. We have 7,200. It's about 11% of our population, but that's a daunting number. And that one was a little harder for us to get our arms around. And in a minute, when we look at the HMO populations, you are going to see that you have an even, like almost double the population. So it's a little even more daunting for us. And in the low risk bracket, we were grateful to see that we had about 88% of our population there. Go to the next slide. So really what the challenge here is, and now I'm going to go back to like looking at both the HMO and the ACO populations for Gwen and I, was that we had daily work. Care management was considered an essential worker function throughout this pandemic because our work is constantly there. We're constantly having to touch lives and interface to really make a difference. So on top of the daily work, they identified 2,700 patients between our ACO lives of 348 and our HMO lives. There was about 2,300. We had a lot of patients on our hands, and this was the beginning of April. And we had about 2 weeks to really figure out, while this algorithm was built and we didn't quite know our numbers, to figure out what kind of strategy and how we were even going to get enough workers to pull together to do this. So we did have a work team. We obviously were staffed for our daily work. We have nurses, we have care coordinators, but really diverse backgrounds. And some of the workers that we pulled in were a section of our organization that were more or less experiencing a very decreased volume of work. So these were our nurses who do review, both on the inpatient and outpatient side. Some of these nurses have not talked to patients in a long time. They've been doing a lot of data mining and a lot of reviews. So we had a lot of training needs and different things that we had to think about, and tools that our team would need to really make this efficient so that they could get in and get out and get through this assignment. We were told by our administration time was of the essence. If we're at risk for these people, chances are they're scared, they don't know what to do. We want you to reach out to them and make a connection. But on top of all of this, the pandemic was hitting all the workers. We had been all sent to work from home. This was a completely new experience for us to work in. And a lot of us needed education and reassurance because we had a lot of uncertainty and exposure in our own lives potential. So there was quite a few things for us to mitigate or organize around. But I think I heard this earlier, that in the midst of difficulty lies opportunity. And that's pretty much how I thought about this opportunity for us. So I called it a challenge, but I'll interspace to say an opportunity. Let's go to the next slide. So what I called this one is our playbook. And I really divided this in two areas. There were the workforce needs and there were the member needs. The member needs, we always feel very strongly about as nurses. We have a lot of insight and feel we can make a lot of connections, but we were looking for highly credible resources, and our data scientist was very helpful in getting a lot of those things from the CDC for us together, as well as reaching out to the Orange County and LA public health departments so that we had very credible resources, and also considering language. But for the workforce, I've already intimated here, some of the nurses that we were redeploying had not done cold calling before. My team in the ACO has, but nevertheless, this requires scripting, it requires dialogue coaching. And the tools that I've trained my team on in the past, which I heard of today, is motivational interviewing. It's not enough to just tell a patient what to do. You have to find what drives a patient behavior. So what it requires is the ability to call and to be able to engage and connect very quickly and ask a series of open-ended questions rather than yes/no type responses, to quickly get to the core and get a connection with someone. And one of the areas that we really found we got a lot of traction on is, after we introduced ourselves, said where we're from, why we were calling, how are you keeping yourself safe? I cannot tell you how many dialogues this opened at a much deeper level than you might think. In many cases, patients would literally start crying. They were lonely, they were scared. In some cases, it didn't make a difference, but we used it consistently. And one of the things we did as far as developing job aids is we embedded questions that we thought would help screen the patients to make sure they had what they needed as far as meds, if they had symptoms, et cetera, but also in safety and with, who's in your household and how to keep yourself safe. So we did a lot of work there, and Gwen's team deployed some of it, my team did, and we just brought it together very quickly. And because we had executive sponsorship, we were able to even go at our EHR Epic, and really this is where we documented everything for our care management. we were able to modify and embrace it so that it would really support what the nurses were doing. Anything from smart phrases, communication to physicians, we embraced it, we got it going, and then we did the training as quickly as possible. One of the areas that I mentioned earlier in the talk was that we had a lot of network resources, but we had to change on a dime. Our institutions were told, our hospitals, to stop doing elective surgeries. We had to get ready for the surge. Our navigation center, which is a one-stop shop where patients can call, we're really able to field a lot of questions, and we were able to work in partnership with them and do many warm handoffs should a patient need to be set up for a virtual visit or perhaps testing and what our criteria was. So we worked with multiple parts of our organization, and we were able to really leverage a lot of partners. And with that exec sponsorship, it was golden. And one thing I forgot to mention, just going back, is we got weekly system updates about how our system was doing in response to COVID. So the nurses felt they could hear from the executives. At first it was daily, then it became weekly, but they always knew and were up to date on what to do and where to send patients. Let's go to the next slide. So this slide, I think I have one more hit on this one for some circles. You can progress, thank you. So here's our snapshot of the number of patients, which you saw earlier. This time you're only seeing what is the extremely high risk and the high risk. And then one more time, please. Okay, and so over here is the percentage that we actually were able to reach and engage in care management. So you can see we were able to engage 112 of the 348 patients, which is a pretty high percentage rate. And I have to say that the cold calling, the different way the nurses are able to dialogue and talk, and the fact that we even did some training to some Spanish-speaking support staff, we did whatever we could if we knew they only spoke a certain language. But you see, we didn't penetrate near as much on the high risk. We got about 8% there. And we touched about 5% of those two populations. This is a very transactional, it takes a lot of time, and you have a significant number of people that perhaps you couldn't reach. But one thing we did find during the pandemic, particularly in April, people wanted to talk. We had members that were at home trying to work, maybe not, maybe they were on furlough. There were a variety of scenarios, but they really gave us a huge chance to connect, more than we've ever had. So we found that opportunity within the pandemic. Let's go to the next slide. Now this is the HMO population. Just to frame it, there's about 135,000 lives. This is a mixture of your commercial and your senior or Medicare Advantage lives. So right away you see 2% of the population, whereas in the ACO population, where it was all commercial, it was 1%. So we have a lot more disease burden here. And the other thing you'll notice is at the high risk, they had 29%. In the ACO population, it was 11%. So looking at this, this is a lot of patients. They again have a good rung down here, about 69%, and they're low risk, whereas the ACO had about 88%. So we can definitely see differences in the population. And we actually did use a little different strategy for this population. Let's go to the next slide. All right, and this is one, if you can do one more hit to this. Very good. So at the extremely high risk, we have this 6% of the patients, and of those, we were able to engage 695 or 29%. So it's very similar to the ACO population, where we had about 32%. It is a numbers game. We do have the ability to use the phone, of course, but sometimes you don't have good phone numbers. And the other thing is, some people, we don't get phone numbers on the enrollment document or file. So we also use MyChart and Reach Out, which is a part of Epic, and that sometimes helps. But in this case, let's do one more circle. For the engagement of the high risk, I was very impressed that they could hit 12% of these HMO lives. And part of this was there was a dedicated workforce that were normally doing reviews that now are being solely deployed to push at this. And they went out this every day all the way through, whereas the other care manager worker force had other assignments and had to make those difficult decisions. But overall, I think we touched an incredible amount of lives. And so for the HMO, this represented about, I'd say about a month's worth of work that they went at it. Where in the ACO, we tended to keep going with it because it intertwined with our risk stratification assignment. And then I have just one more slide that I wanted to go through, and it just touches the heart of making a difference and what we found. This story was actually published in our weekly COVID update as a memorial hero story. And in this case, I'm giving you pictures of our social worker, Valerie, and Marianne, the nurse. And we had a patient who was on the extreme high risk of mortality. And this was a 62-year-old female who had an outreach call. She had diagnosis of multiple myeloma, but really had been doing fairly well. But because of her anemia, leukopenia, she was very strict with her social isolation. And by the time our care manager made a call, she just burst into tears. She was one of these folks that really discovered, or we discovered, how lonely this isolation period could be and how scared you can be and how not everybody has a lot of connections if they can't get out of the home or they're frightened. So we were able to do a warm handoff from the nurse care manager over to an embedded behavioral health model that we have in our PCP offices. At this time, it was a virtual. So Valerie, our social worker then, was able to do a little bit more triage over the phone to really see what level of care or support might be needed with behavioral health. And then Valerie did make a referral to a behavioral health provider for this member. And over time, she continued to do some weekly check-ins just to have a social, check-in for this patient. And this patient greatly did well. She stabilized emotionally, was incredibly grateful for the intervention. And this is just one of so many stories when you think of all the patients that we touched. And just to know that care management is a transactional type intervention, but when you use a population health approach to really strategize and figure out which are the members to target, I think you can have a lot of success. And this was Memorial Care's story. We do intend to study over time how this population does, but we wanted to give you as much information to see if perhaps any of these caveats perhaps could be taken or strategies to your organization, and you could work through that. So I'll pause. I know that there's another presenter and maybe some questions.
Hi, Linda. This is Cindy. Can you hear me okay?
Yes, I can.
Great. Well, thank you very much for the presentation. We appreciate all of your insights. We've gotten a few questions in the chat room that I'd like to pass along to you.
Okay.
The first is, can you tell us more about the risk of mortality being associated with a learning disability and where that aspect came from?
I had the exact same question because I thought that just doesn't make sense to me. So Dr. Mike, are you on? Would you like to respond to this one? I don't know if we can unmute Dr. Ranawa. If that isn't possible, I will.
Hi, can everybody hear me? This is Mike.
Yes, thank you.
Yeah, hi. So a great question. So that was something that the UK system put in there, and they had in their algorithm defining that as one of the attributes that attributed to you having a higher mortality risk for mortality. And I think probably has to do with their ability to manage their care is kind of what I'm thinking, but I have not looked into the research of it where they're actually coming up with that.
Thank you,
Thank you. And Hattie, do we have time for one more? Can't hear you, Hattie.
Oh, so sorry. Yes, I was muted. Dr. Sperling was very interested in this presentation, and Dr. Sperling is muted. So if you could unmute yourself and comment. Thank you so much.
Yeah, so Linda, thank you to you and your team at Memorial Care. This is really tremendous work and really teaching us all about the approaches we need to take, even when we don't have the people power and the wherewithal to take on these type of really frontier and pioneering type of programs. So this clearly needs to be shared with many. And coming back to the question of ROI and prevention, you know, a similar model clearly could be created related to cardiovascular disease prevention, and you'd have this pyramid of risk. And what we know is from the World Health Organization, there's a concept called best buys. And best buys are those living with heart disease, prior stroke, diabetes. And then there's a lot of talk about a polygenic risk score, but really there's also a similar talk about creating a polysocial risk score, because social determinants of health clearly play into risk. And I was wondering if you added those social determinants of risk, such as zip code, into your risk equation and risk determinants.
We definitely have the zip code. We use that for geomapping for alignment or attribution. But as far as putting in the social determinants, I think that is just would be a really insightful thing. And I was thinking the same about cardiac disease, because once we risk stratified, which we did just over on an overall population, not per se for COVID, Dr. Mike came in and said, oh no, we can layer in and do this just for COVID. You could do this for any disease area that you wanted to tackle, right? But some excellent ideas and more for us to work into. I would agree with you, because if you can't get to food and you can't get exercise because your environment isn't safe, it's a whole different ballgame.
Dr. Chen, you're there in Southern California. Thank you for your leadership over the years from the University of Southern California. And I'd like to say we've had with us some of the major health systems across the state with us today. Very impressive group. Steve joins us from the University of Southern California School of Pharmacy. Would you like to comment on this?
Yeah, I just have to say, Linda, that's got to be one of the most tremendous efforts I've seen, being very proactive and practical to help very high-risk patients. So I commend you on this work. This is not a small effort, and you talk about it like, I'm really impressed. You know, it just sort of reminds me of some of the work we're doing as well, working with LA Care and Inland Empire Health Plan on trying to identify high-risk patients with uncontrolled chronic disease, and we're following your path, right? We're trying to create algorithms for risk. We're trying to combine social determinants of health with markers, as you are, to try to proactively pick out these patients that are headed down a path where, you know, they could suffer from the outcomes of the poor outcomes of cardiovascular disease, diabetes, and so on, mixed layered on top of COVID. So I'm going to reach out to you after this and ask you for some insights, if you don't mind. I thought this is a tremendous project that you've conducted, so congratulations.
Oh, thank you so much. And that would be a sheer pleasure for our team.
Thank you.
Hi, this is Carol. I have a comment question for everyone. I think today's topics have been very nicely woven into one another and present a lot of opportunities as we start out with Dr. Sperling saying, and also challenges. Hattie knows I like to think of life in simple number threes of things. So if I were to say, looking at the presentation today for just this one topic, two topics really, I look back on my clinical practice days as trying to merge a circle and a Venn diagram. So one circle is the clinical practice, experience, judgment, etc. And another circle might be the science, the studies. And in the old days, which I can remember, unfortunately, sort of, the science didn't come out as quickly as it does today. I mean, I think in medicine, we're bombarded with new studies and slices of studies and segments of diseases. And then that may change in the next year. And so we're constantly being bombarded with the science. And then looking at another circle in this Venn diagram, perhaps, is the data. And how do we integrate all this data so that we can get those three circles of a Venn diagram to really overlap more than just a little bit. And I think that might be a challenge. It's a challenge to the healthcare system, to the patients, and to the providers, as to how can we make that robust convergence of these three circles, and also make it so much more practical to the provider and the end user and all of the components that Linda just talked about. It seems hard perhaps at times to wrap your arms around it. So are we still a little fragmented in looking at disease slices as intimately as we are now, and really getting to really granular levels? But I think that might be a challenge for the different aspects of the healthcare system. That's just my comment.
I love the Einstein quote that Dr. Sperling reminded us of, that in the midst of difficulty lies opportunity. It really defines our work. And I'd have to say, it's been so hard to watch many of you who are frontline providers. People are losing sleep, the hospitals are overwhelmed, and everybody's just working so hard to try to stay safe. And the work that Linda just presented, I think really would help all of us, because we know that heart attack deaths are highly preventable, and that by deploying the right care, I call it the holy trinity of the right care initiative: control that LDL, the blood pressure, and the blood sugar. And we're going to drive down, as you see on the graphs behind me, heart attacks very, very, very quickly. So when Larry talked about, Dr. Sperling talked about the percent of patients who are not at goal for these basic metrics, what's so critical right now is that if we're able to innovate, to find a way to proactively get those patients on optimizing their medication therapy, for instance, through the wonderful support of the pharmacists on the care team, we may be able to lower the pressure on our healthcare staffs and our frontline providers who are there in the hospitals, who are overwhelmed, who are having trouble getting the personal protective equipment that they need. And it's just imperative that we think differently to keep those events that we can prevent from occurring. So I have to commend all of you, and I don't want to shut down this discussion. We'll stay on as long as people want to ask Q&A. I don't know how many of our speakers will stay with us, but I'd like to turn it back to Dr. Bommer to comment from his standpoint from UC Davis Health System, which has really been bearing quite a brunt of this pandemic. Thank you, Bill, for your incredible leadership throughout many years of right care.
Let's see, I should be off mute. Can you hear me?
Yes.
Okay. Well, these have all been incredible presentations today, and we certainly appreciate everybody's effort with that. A couple of things. One question I will address to Larry that came in the chat line, and that is, yes, we have that study from Germany that shows post-COVID patients have potentially residual disease. So let's say somebody, even some of those individuals were asymptomatic or mildly symptomatic. So let's say we have a patient and they recover from COVID. When do they start exercise again if they were previously doing it? Or even if they haven't, take our recommendations to do it, when 50% of them may have some cardiac MRI abnormalities or late gadolinium enhancement, we have to worry about subtle or low-level myocarditis in those individuals where we could potentially worsen them. Should we wait a period of 1 month after all symptoms go away, or 2 months, or what's the standard? What would you recommend?
So a really important question, Dr. Bommer. I've gotten used to answering a lot of questions by saying at this time, because right now we are evolving and adapting, real time. And so we have to look at that single study out of Germany with at least raising a question mark. You know, the average person we help care for is not an NBA basketball player, but I know the professional athletes who are, you know, COVID positive, they're doing a battery of tests on them before allowing them to come back. I think for our general patients, we need to recognize the possibility of subclinical myocarditis and its impact. I think right now, as a clinician, again, not as a scientist or speaking for any organization, I would ask my patients to start back very gradually, give it a couple of weeks after the medical constellation has subsided. And certainly if there were any red flags, to alert their clinical team immediately, and then that might be a call for additional testing. I'm not sure we can do cardiac MRIs on all of our patients, but you know, especially for those at higher risk, we should give them appropriate counsel to be cautious and careful, and hopefully we will know more. There's a COVID registry, COVID in the Heart registry being spearheaded by AHA, and then I'm working with the World Heart Federation on a global level. So lots of questions, we need some answers, and hopefully we'll have some more information.
So Dr. Sperling asked us to fit in the public service announcements in a few minutes before we wrap. And I just want to say that while we want to urge patients who are afraid to go in to go ahead and get their flu shots, can I just ask everyone for the innovations that are going to possibly allow those flu shots to be given in the out of doors where there isn't as much risk of potential infection. Could anybody address that, please?
I will. Let me just, only about 45% of adults are receiving flu vaccine by the last year. And so there are many barriers to that. And I think what we have to do is create, as Hattie mentioned, a very trusted and confident scenario for this. Whether, I mean, if I were going to design a plan, it might be outdoors and even at pharmacies. When you talk to patients right now who are fearful, the only place they've gone besides their home is rarely to a grocery store and rarely to a pharmacy. And so whether we set this up at grocery stores or pharmacies outdoors, along with clinical teams, but these, you know, capture moments may not be the same as we're used to in the clinical realm itself. So I think this is really important for us to think through proactively. And so maybe Linda and her team at Memorial Care can design, you know, a strategy here as well that's proactive and preemptive.
Yeah, this is Dr. Brooks, Oliver Brooks. We're doing now drive-through testing. So we're looking at converting our drive-through testing program into drive-through influenza vaccination because we feel like we're already set up for it. And it's easier to give a vaccine versus doing the testing.
Yeah, and we're working with the state pharmacy organization to work through health plans and local governments to do the same thing. So drive-through, like you said, drive-through flu immunizations, administering them in pharmacies. And, you know, there are 15 pharmacy schools in the state of California with thousands of students that, you know, need to do this as part of their training. So the workforce is largely going to be pharmacy students for us.
All great ideas.
I know that in California, we've done a lot of setup to do outdoor testing and so forth. And I love the idea of transitioning from the testing to the vaccinations. Does anybody have that up and running yet? Or I guess we won't know for a little while. When do the flu shots start making sense, Dr. Sperling?
Yeah, again, not being an expert on influenza vaccination, what my take on it is the earliest you should think about it would be September. You know, when the vaccine is available would be late September into October. There are all kinds of theories about when you would want to have your flu vaccine in terms of having the the greatest level of antibodies during flu season, but probably right now with the high likelihood of coincident influenza and COVID, although lots of speculation if we wear masks and we socially distance and we wash our hands, we not only will, attenuate the curve of COVID, but we can also attenuate the curve of influenza.
So right after I saw you in January, Dr. Sperling, just a few days later after flying home from Southern California, even though I had the influenza vaccination, I got influenza A, H1N1. And as many people on this call know, after I was tested positive for the flu, a very fine healthcare institution, sadly, instead of handing me the Tamiflu that they urged me to take immediately, they sent me to a 24-hour pharmacy where it was a nightmare. There was nowhere to sit, there was no hand sanitizer, there were no masks, it was indoor, and there was a lot of people coughing, and there were even drug addicts in the midst. It was a frightening situation, and I think just thinking systematically about if you get a positive test, you should not be then sent out into the world to infect other people. So we need to think systematically here, and it's a great moment for innovation.
Well, Hattie, I think we have our work cut out for us as far as the innovation and in getting the personnel to do this. The reality is this is CoV-2, so this is not our first rodeo. This is more than one. We can expect other viruses like this to come along. Larry's point, I would recommend early flu shot just so that you take that out of the equation. So if someone gets sick in October or November and they've had flu shot, we can reduce the chance that they come down with influenza, which can look initially like COVID-19 at the time. So I think it would allow us to focus a little bit more, or that is possibly COVID is their infection. But we certainly raised the issues. Linda very well presented a very comprehensive program for tracking these individuals who are high risk and making sure they have the appropriate care. I'm impressed with her relatively low risk population of 88%. That's nothing like we see at our hospital healthcare system, where it might be the opposite at that point, who are high risk. So that's important. I wanted to ask Linda how many people it takes to do it, because in our hospital we had a reduction in inventory for a month of April when we phased down as the recommendations. But by May, it came right back up, and our census is right at the same high level. Were you able to get these individuals for tracking out of your healthcare system to do this extra work? And was there a suffering because you removed them from utilization management or other jobs that they had?
Hi, Dr. Bommer. This is Cindy Giambroni speaking, and Linda had another appointment at 2:30, but I believe Gwen Mertz might still be on the phone because I see her sending questions in the chat box. And Gwen is Linda's colleague that works on the HMO side of the business. So Gwen, can you unmute yourself and address the question?
Sure, can you hear me?
Yes, thank you.
Yeah, as far as the HMO population, I think everyone knows that once we had that 2-week beginning, I'll never forget, at the end of March, the beginning of April, obviously across our health system, in preparation for a potential surge, we decreased all of the electives, so they stopped. And also, as you know, patients stopped coming in. And the staff that we access and utilize were mainly those that were impacted by patients not going to the doctors and our skilled nursing facilities. So if you don't have patients going into the hospital for knees and hips, they aren't going to rehab in a SNF, right? So we were able to pull staff out of our skilled nursing facility assignments as well as our referral management assignments, because our referrals went down at least by 50%, if not more. And you're right, towards the end of May, mid-May to end of May, our numbers started coming up. And then when the governor allowed the essential electives to come up, we started seeing those. And we started kind of repatriating some of our non-COVID patients into our health system to get our census up. And then we had our secondary surge in late June and July. That's calmed down. But we definitely have higher volumes in our hospital, especially on our medical group side. And I think it bears saying that, and our hospitalists say this as well, people have neglected to go to their doctors, and they are coming in just so sick, where they normally would have shown up in the emergency department or gone to their primary care earlier. And even though we've converted into what was like a 90% telehealth, we're now down to about 20 to 40% telehealth. People are not accessing care like they used to. So our system is doing a lot of promotion, as they are in Los Angeles and some of the larger health systems, to have patients go to their doctor. And I think that's still where we are. We haven't recovered at the SNF level for many reasons, and part of that is because of the COVID impact there and the slowness of CDPH and other health organizations to get in, but that's been rectified. But overall, all our patients, at least on our employed side, a lot sicker. And then we're kind of at the tail end of the COVID inpatient.
Well, thank you very much. If there's other questions, you can put them into the chat box, and we will keep the chat box open for the next 10 or 30 minutes if you want to enter those. And we will hopefully get back a response. Also, for those individuals who want credit, CME credit for today's program, go into the chat box and there is a link to SurveyMonkey so that you can actually get credits, CME credits for your licensing or whatever you need them for your institution for that. And I think that based on that, and there are the instructions again for CME up on the screen on SurveyMonkey. But I'd like to, I think you're all busy individuals. It's 2:50 at this point in time. I know you're incredibly busy, and we really appreciate you taking time out from your busy day to join us today. We certainly want to thank all of the participants who have been on the call. Your questions and feedback have been very helpful to us. We want to thank all of the speakers who have been, who devoted a lot of time to get their talks ready for this and your involvement in it. We want to thank the facilitators who have been very good in monitoring for the first time our combined raise hand and chat feedback Zoom protocol for today. And we certainly want to thank the individuals with Right Care who have been under the radar, but performing all of the coordination, advancing the slides, getting the slides ready, and allowing this production to go out. And so I think with that, I'll turn it back to Hattie for a final word. I don't know if she'll quote Yogi Berra or not, but I'm sure she has at least one final word that goes beyond risk factors. Hattie.
I guess my favorite word is communitarianism. and how we are all coming together to address multiple crises, multiple interacting threats to our own lives, health systems, and patients, and just thank everyone so tremendously. And I want to say that Dr. Sperling did provide us with some potentially very useful resources that we will be sending out through our post-meeting communication. And for those who'd like to stay and see the public service announcements that the CDC Foundation has worked with Million Hearts in creating, Dr. Sperling, do you want to say anything about that before we run those at the time of your
Yeah, they're 30 seconds each. And so for many reasons, we kept these short, but coming back to Dr. Bommer's introduction to our meeting today, that as you'll see in the first PSA related to acute events, that an event occurs during each one of those PSAs in our country each time it's played. So every 30 seconds or so, there is a cardiovascular event. And you can do the calculations based upon our meeting time today about how many cardiovascular events have occurred in our country. So we all have a lot of work to do, COVID related, and then keeping cardiovascular disease prevention a priority. I want to thank you all again for all you do.
So I think our staff may be a little distracted because I know that they had that queued to go. Megan, could you please put the public service announcement on? And there we go. Okay, thank you for starting that. Do we have sound?
Heart attacks
No.
are medical emergencies. If you experience symptoms of a heart attack or stroke, do not delay seeking care. Call 911 immediately. Hospitals are prepared to safely treat you. Visit cdc.gov/coronavirus to learn more.
I think we were having a little bit of a problem with the audio on that. Not sure why, but we will be sending these out and we'll try the next one with the sound on.
Heart disease can be life-threatening. During COVID-19, managing heart disease is essential. Take your regular heart medication. Focus on your health. Reach out to your medical team for questions, concerns, and continued care. Your heart is 1 in a million. To learn more, visit cdc.gov/coronavirus.
Beautiful work, and we will make these available on our website as well. The Right Care website has many COVID-19 resources along with cardiovascular at this point. And I just want to say how amazing it is that Dr. Sperling in January, Friday, January 17th, I remember him saying, well, Hattie, I can present by video from my desk. And I'm like, it's hard for me to believe that, but here we are, 7 months later, and we have you with us from Atlanta. So your vision that you expressed at dinner with one of our early grateful patients, Judy White, and some of our early San Diego leaders, where you said, let's take this national, let's start it next in Atlanta. And here we are, we've figured out through being forced to innovate that we actually can work together nationally. And it's just such a blessing to know you. And I so appreciate the hard work. Here you are emailing me that you're, seeing patients so many hours a day, and yet you fit us in, and thank you for that. And thank you for your amazing public service, not just to Dr. Sperling, but to all the wonderful physicians, pharmacists, and healthcare leaders from around the state. It really is, and country increasingly. It's just so heartening that together we can support each other, and through this Zoom platform that I believe was created at Stanford, we're all able to continue meeting and supporting each other in our mutual quest to improve lives. And I just can't thank you all for your leadership enough, and also to thank our staff that has been working really hard and learning so fast, so many new things. And Dr. Sperling, do you want to just say a few final words before we let you get back to your patients?
Just thank you again for including me. A wonderful virtual visit with all of you in California and around the country. And I just say, take it one day at a time right now. I think all of us do what you can do for your health, your family's health and well-being, your community, and together we will get through this. And so just keep at it. And again, thank you. Appreciate that. Bye now.
Lovely to see you. Thank you for visiting with us.
Bye.
Thank you, everyone, and have a great afternoon.
Thank you, Dr. Brooks.
Thank you.
I see you're masked up, and I think it's kind of amazing what everybody's going through, but I think it's easier because we're going through it together.
Yeah, and you're right. Misery loves company, as my mother used to say.
Well, hopefully we can trade a few best practices that help keep each other strong. And it's been kind of interesting that during even our weekly planning calls, I think people are really appreciating seeing each other and just touching base with kindred spirits who are in this fight together. So thank you for taking time for us. And with that, we will share with you resources as we can. Please stay in touch and keep your guard up, everybody. Bye now.
Bye. Thank you.
Bye-bye.